Good morning, everyone, and welcome to the 2026 UBC Psychiatry Research Day. First of all, I would like to acknowledge that all of us here and those that are attending remotely, we are grateful for being able to work and live in the traditional, ancestral, and unceded territories of multiple Indigenous and First Nations people. So this is the agenda for the program today. Before I go into the agenda in more detail, I want to thank the members of the organizing committee, Dr. Beasley, Chakrabarty, Murphy, and Ham, all of whom will be moderating different sections of the meeting today, and also to express my gratitude to Margaret Koshy and all the members of our admin team for their incredible efforts to make this day a success year after year. And this year they had a very special challenge because our catering department canceled the order last night, but there will be lunch. And we're very, very grateful that they made it happen in such a very short notice. So a great big thank you to them. So we will start the session after I finished the introduction with Dr. Yatham presenting an update of the state of the department. Then we have an exceptional plenary guest in Dr. Martin Paulus. After his talk, we will have a coffee break for half an hour. And then we will go to our first set of lightning talks where we have presentations from different short presentations covering many different aspects of research within the department. And then at 3 o'clock, we start the final part of the scientific program where we have two highlighted talks by Dr. John Jose Nunes and Dr. Guluxugus covering different aspects of their research. And we finish with award presentations and closing remarks. And with that, I would like to invite Dr. Yatham to give us the State of the Department address.
Well, good morning, and let me also take a minute to acknowledge before I begin that our department and its distributed sites are located on traditional ancestral territories of Musqueam, Squamish, Tsleil-Waututh, Syilx, Okanagan, Layton, and Lekwungans people, and we're obviously very grateful for the opportunity to work and live on these lands. As you're all aware, the Research Day is all about showcasing some of the research that's happening within the department. And of course, research can't happen unless we have adequate resources in terms of research funding, resources in terms of people, and also infrastructure. And I think as you're all aware, research is one of the strategic pillars of our strategic plan. And as a part of that pillar, we obviously have been working on building that infrastructure. So I'm just going to take a couple of minutes to tell you where things are with regards to that. So I'm just going to focus my address just on the research aspect of where things are with the department. So just looking at the research funding, it's just been pretty steady. We're always around $10 to $11 million of funding, research funding that the department attracts. The exception was a couple of years ago, we did go up quite a bit. I think some of that reflected the large amount of money that was thrown in to support the COVID research. So we did go up, but then kind of back to baseline. Now, this funding doesn't include the philanthropic funding that we receive, and we've actually been getting a lot of philanthropic funding, so that's not reflected in these figures. So we do get a lot more money than what you're seeing on the slide. In terms of people, lots been happening. This is just within the last year. You can see we've recruited a number of academic faculty. So Puya Azar has been recruited for a position in concurrent disorders. John Jose Nunes, who you will hear from later on, was recruited for a partner position. Sinon Galoxas, you will also hear from him later on. He's academic faculty member at the Northern Medical Program. And then we have Andrea Wodemeyer, who is the Potter Track faculty that's based at VGH in the liver transplant program. And I was chatting with Linda Raymond last night, and she said, liver transplant? And what's that got to do with psychiatry? And I said, well, she's going to look at the psychological aspects of transplantation. So it does have something to do with psychiatry. And then Hao Ting Wang just started her position here on May 1st. And she's our data science recruit. Roberto Sassi, who has been here for a while, heads the BC Children's Hospital. His appointment got renewed for another 10 years. And then we are very much looking forward to welcoming Aviva Olesavsky to Vancouver Island program as academic faculty. She's coming from the US, and her area of interest is substance use, but particularly in women during the perinatal period. So very exciting recruitment. Also, lots of other recruitments in progress. CRC Tier 2 chair in cognitive resilience. That search has been completed. We have an outstanding candidate that's been offered the position. She's verbally accepted to come here, so we're just sending her the official offer, and we're expecting her to arrive on April 1st next year. The Royal Columbian Hospital academic faculty position, we completed the search, offered it to a candidate, and shockingly, that person turned down the position last minute. Not sure why, but anyway. So that search is going to be reopened again. It's going to be posted this week. I think I mentioned about potential academic faculty position at Interior Health last year as well. And those of you that have been around are aware there have been lots of changes with the health authority in the last 12 months, with restructuring, changes in funding, leadership changing. So we had a commitment from the CEO of Interior Health Authority for funding for an academic faculty position there. And literally 4 months later, she was gone. So when those sorts of things happen, you just never know, what's going to happen. But anyway, since then, we have established the links with the current CEO and the VP Medicine, and they both have reaffirmed their commitment to come up with funding to support for an academic faculty position. So that's in the works, and I'm hoping that this is going to move forward fairly rapidly. There are a few other Potter Track faculty appointment positions that are being explored. And all of you will have heard about these Canada Impact Research Chairs. The federal government has put in massive amounts of money to attract top talent from outside Canada, particularly using the turmoil that's happening or going on within the US. So trying to attract top faculty. So we put in an application from the department identifying an incredibly well-known researcher whose work has potential to transform discoveries for treatments in for a number of brain disorders. And his application has gone through all the UBC steps. The only step remaining is approval from Ottawa. So we're optimistic. Sophia has been instrumental in supporting this application. So thank you, Sophia, for doing that. So I'm very optimistic that this will go through. But again, one never knows these things. We're also exploring funding for other faculty positions. We have a verbal commitment that we might be getting another $7 million to support research related to bipolar. So some of that money probably is going to be used to create an academic faculty position, some of that for education and research. So lots of things happening from the research perspective in the department. And of course, as we recruit new faculty, we're also seeing some of the senior faculty beginning to think about retirement. So we are likely going to see two of our very well-established senior faculty retiring this year and early next year. I'm not going to say the names now because it's not official as yet or public as yet, but we will once it's all confirmed. So that was all about the faculty, but also we do other things in terms of stimulating research. And as you're all aware, we have been running the Marshall program with the generous philanthropic support from Marshall family. They've actually given us way more money than they had initially promised. So we still have a lot of money to continue to continue this program for the next several years. And we support 4 fellows. We have money to support more, but we want to make sure that we identify the top candidates that have the potential to pursue academic career. And these fellowships, half of them are earmarked for MDs because we recognized a few years ago that many residents graduating from our program want to pursue research career, but have had limited opportunities to get funding to support research training. So half of these are reserved for MDs, and you can see the 4 candidates that have been selected for the fellowships this year. One of them, of course, is Vivian Xiang, who is one of our graduating residents this year. We also have a stimulus grant initiative, which supports research by clinical faculty and also junior academic faculty, and that's running quite well. Sophia runs the program. The applications for the next cycle are they're open now, and I think they close sometime in October, if I remember correctly. Masters of Health Sciences and Psychiatry program started with leadership from Ray Lam, and that's going well. We have candidates from psychiatry that are going through that. So Ray and Daniel support that program from psychiatry perspective. And we had $200,000 funding that came to the department, and we were trying to figure out what do we do with that. And eventually we decided that we would endow that, and the income that endowment generates could be used to support tuition fees for a woman candidate that gets enrolled into Masters of Health Sciences and Psychiatry program. So it's a new opportunity. So if any of our residents or other grad students that are interested, this might be something that you may want to think about applying for. We have tons of people that have had awards and honors, published high impact research, are doing some of the outstanding stuff. So I'm not going to go through the full list. The one thing that I did want to highlight, though, is the Terry Snatch's accomplishment. So he's one of the people who has been working on this calcium channel blockers, and he's identified a drug which went through phase 2 and more recently phase 3 trials for treatment of benign essential tremor. There's no other drug, and those trial results came out in the last few months, and those are positive. So the drug is going to be approved by the FDA for treatment of benign essential tremor, and that came from research from UBC Psychiatry. So lots of good stuff happening. And lastly, you will all remember the department went through internal review about 2.5, 3 years ago, and we're now going to go through the external review this year. The reason being, not because we're doing badly or anything like that, but apparently there's a 10-year cycle. So the last external review for the department happened about almost 11, 12 years ago. So we're due for an external review. They were going to do it last year, but we sort of postponed it because it was so close to the previous internal review. So this is going to happen later this year. So I urge all of you to participate and feedback, because obviously we want to hear from you. And if there are any suggestions, please do let the reviewers know so that we can use that to develop a refresh of the strategic plan, because our previous plan was a 5-year plan, and most of the things that we said we would do in that plan, we've accomplished that. So we need to refresh. And we thought, instead of doing it now, we thought we would wait for the external review to be completed, which hopefully will have feedback from all of you. So we'll take that plus the consultations that we will do as a part of that strategic plan, and then come up with a new plan that's hopefully good for the next 5 years. So that's all I had to say in terms of the highlights, but I did want to reiterate what Sophia has said. She and the rest of the committee has put together an outstanding program. Enjoy the rest of the research day, and thank you for coming.
Now it's my great pleasure to introduce our outstanding plenary lecturer for this year. It's Dr. Martin Paulus. He is the director of the Laureate Institute for Brain Research and professor of psychiatry at Oxley College of Health and Natural Science at the University of Tulsa. He has had an extremely distinguished career, and I will not even try to summarize his accomplishment today, just to say that his expertise spans psychiatry, computational modeling, behavioral modeling, and more recently, he has been having an increasingly consequential leading role within the evolving field of AI in psychiatry. He is also deputy editor of JAMA Psychiatry, and it is a great pleasure to have him amongst us today, and I welcome him so that he can share his thoughts with his presentation with us today.
First of all, I want to thank the organizers. I want to thank Sophia in particular for having me here. It's very excited to be here, actually, in Vancouver in British Columbia. It's been 45 years since I first came to Vancouver. Back then, I stayed at the youth hostel just a few miles down and traveled up to Whistler and then to Prince George, Prince Rupert. Spent 2 miserable days in a tent in Prince Rupert, and then took the Inside Passage and had some glorious days on Vancouver Island. And so very fond memories. Hard to believe that it's been that long. But I'm very impressed by the department. We had a fantastic dinner last night, and it's great to see sort of the variety of research that is being done here. So I'm very much looking forward to the poster session and talking to people. If you have any questions, please approach me. I'll be in the hall. So I'm very much looking forward to this. So hopefully I can operate So I've been thinking about what to talk about. I am the scientific director of a small research institute in Tulsa, Oklahoma. I used to be at the University of California, San Diego for almost 30 years. And then a private foundation approached me and made me an offer I couldn't refuse. I've been there now for the last 12 years. And the Research Institute focuses on using neuroscience-based tools to try to make advances in psychiatry, which has been very difficult to do. Many of you know that. We've been trying to understand the mechanistic basis for our disorders, and we've been trying to figure out how we can use tools such as neuroimaging, but then also molecular tools to really make a fundamental difference in how people with mental disorders struggle. And, we still are, I think for the most part, in a situation where lots of discoveries are made serendipitously. Not necessarily based on first principle, because we understand necessarily the pathophysiology of the disorder. I say that because I want to kind of give a little bit of broader history of what I'm actually going to present to you. So 5 years ago, I would have basically told you about neuroimaging and would have possibly be somewhat hopeful about neuroimaging being a objective marker for various disease states. I have to say I'm less optimistic, although I'm not completely not optimistic. But I think that the job is much harder. We've seen over the last decade or so how neuroimaging variables account for the variance that we observe clinically, but that the amount of variance that they account for is rather small, not that much larger than the amount of variance that is accounted for by genetics. which makes it very difficult for us to use it in a clinical sense. Because what I had hoped for when I joined the Lloyd Institute for Brain Research is that we can create the EKG for the psychiatrist, that we can create a objective measure that, if being taken, can help the psychiatrist to make decisions. And we're not there yet. That's not to say that we might not get there, but we're not there yet. So this is a lot of background to get to what I want to tell you a little bit more about today. So several years ago, I decided to pivot. I probably had my second or third midlife crisis. And that has to do with the fact that as a researcher, you look at your research career. You look at different stages of your research career. And I have to admit that my research career is kind of on a downhill swing. I hate to say that, but you got to be realistic about these things. And what that means is that when you plan for what your research project should be, your time horizon changes. When you're young, you can have a time horizon of 20 or 30 years. You can say, well, we're going to work on this and we're going to really discover something. And that's great. You have to have that. If you don't start that way, you're not going to make it. But as you progress and as you get where you can see, that the whether it's the light at the end of the tunnel or whatever metaphor you want to use, your time frame changes, and therefore, in some sense, the kinds of research questions you can ask change. So I'm getting to what I'm going to talk about. I know I'm looking at the clock here, but so I pivoted. I pivoted and started thinking about how can we use large-scale data that's already there. It's incomplete, it's complex, it's problematic, and I'll talk all about this. How can we use existing data to potentially use a predictive and hopefully maybe even a causal framework, and I'll talk about that too, to make discoveries that actually might help to change people's or healthcare providers' decisions within a few years, not within 10 or 15 years. So that's sort of what I've been thinking about. And then something really strange happened. I got very early on into large language models. So when people weren't really kind of thinking about these things yet, this was before even OpenAI released their GPT. And almost immediately I saw enormous possibilities. So I've been kind of stuck with it. So I would be talking a little bit about how we might be able to use large language models or general AI in this context. I felt really energized by the emergence of generative AI, and I'm happy to discuss with anybody who wants to. I'm also aware of the problems, and there are problems, but I think there are great opportunities that we can potentially use. Okay, so that was a lot of background, and so I'm going to talk about counterfactual treatment optimization, although I will leave that actually to the second part of the talk because I have to set it up a little bit. So first, I'll be talking about treatment-resistant depression. So this is how we started. We now have a pretty good-sized group at the Lloyd Institute for Brain Research that focuses on using electronic health records to identify and operationalize the term treatment-resistant depression, because we can. I'll talk about this too. And we got into this actually because we were reviewing other people's work, and they were working with the All of Us database, which is a very, very impressive database that is a large scale, still ongoing study in the United States that uses electronic health records and also donated blood samples. And the blood samples have been genotyped, and that allows us to actually look at the biological basis of things like treatment-resistant depression. Through that, we've developed more tools and techniques, and then that's how we got into the counterfactual treatment optimization. And I'll be talking about what it is, how to implement it, what are its challenges, and I will tell you, I'll show you some preliminary data. This is very much still work in progress, and we're still refining the approach. But I wanted to share that because I think that there's some really interesting questions that this approach raises that I think would be important to discuss. Okay, so here are some of the people that have been helping me. This is always a group endeavor. The first thing we were trying to do is to see whether we can actually identify people with treatment-resistant depression from electronic health records. And I'll tell you a little bit about this. So as clinicians, many of you know that the standard definition of treatment-resistant depression is that you have to have failed more than two standard antidepressant treatment trials of sufficient duration, sufficient dosage, and the failure is typically defined by either residual symptoms or that you have side effects that are not tolerable or incomplete response of some kind. Sometimes you also include function measures. So right off the bat, that is a significant limitation of what you have when you deal with electronic health records, particularly if you're dealing with electronic health records where you only have the structural element of the health record. The structural element would be, like I said, the diagnosis, the procedure codes, lab values, things of that nature. If you don't have, and in many cases you don't, say have patient-reported outcomes or notes, then you have significant information deficit. A number of groups have been working on this, and we adopted an approach that the MGH group has used, where they operationally defined treatment-resistant depression within a particular time frame, looking simply at the the medication records, and then defining TID as more than two antidepressant treatment on record within a certain time frame without an interim break, and that's basically what we did. So when we did this, we actually looked at the All of Us database, which we had data of about a little over 400,000 people. Of those, we identified about 60,000 with major depressive disorder based on the ICD records. Of those, about 43,000 were medicated, and of those, we could identify about 8,000 with treatment resistance. As I just said, more than two antidepressant treatment within a year. And then we looked at how much data we had on these people. And we also looked at how many of those had biological data, and I'll talk about that in a moment. The prevalence is actually very interesting. So there a number of different groups have looked at the prevalence of treatment-resistant depression. And depending on the cohort, it varies somewhere of the order between 15 to 30%. We were actually right in that range. And there have been some recent studies looking at various thresholds of defining treatment-resistant depression and in a number of different cohorts. And they also identified about 20% of people with treatment-resistant depression, which is quite significant because, as we know, treatment-resistant depression goes along with lots of other things. So The first thing we identified and looked at is what is actually the treatment sequence. The obvious thing that we're finding is there is no obvious treatment sequence, that many treatments occur in many different orders. Typically, as you can see here, the treatment-resistant depression trajectories are not that different than the treatment responder trajectories that you can see here. About 40% start with an SSRI, but then you can see there's all kinds of shifts to SNRIs, TCAs, atypicals, other SSRIs. We see, of course, a lot more switching, but there was no clear trajectory that led to these three instances that we used to define TRD. We then look at what are other characterizations of those individuals, and we were basically pretty much oriented based on a large review that had been done on treatment-resistant depression a number of years ago now, that looked at the characteristics of the course of TRD, what context, the comorbidity, and some of the biologics. So we know that in terms of context, that people with other comorbid psychiatric disorders are much higher risk for TRD, that severity plays a role, and that also early childhood trauma and things of that nature have a very strong effect on TRD. What we looked at in the All of Us data, we found that those individuals, which isn't too surprising, that were unemployed or not in the labor force had a higher rate of subsequently developing TRD, that having higher education had actually lowered the risk, having higher income. I think what that reflects is just access to treatment and access to health access. On the other hand, being unmarried and having low income had a higher risk for subsequent treatment resistance. When we looked at the comorbidity, not too surprising, people with treatment-resistant depression, as defined, as I said, had high rates of comorbidity, anxiety disorders, as you can see here, PTSD. This has been reported many times, but what that tells you is that we call these people treatment-resistant depression, but really what it is, it's a constellation of a complex mental health condition that is not necessarily limited to depression. Similarly, again, not too surprising, high comorbidity with substance use, whether it's opioid, alcohol, or tobacco use. This has also been reported previously. But we have to recognize that with these data, we have lots of things that are missing. And this be something that we will have the ability with other records to study and what we're currently studying. One thing that is very big is that while we have the medication prescribed, we don't have any data on the actual medication adherence. And medication adherence, I keep telling this to people, is one of the biggest problems in the medical field, not just in psychiatry. If you look at medication adherence data, by 1 year, 1 out of 7 patients with depression is still taking their medication. By about 6 months, only half of the people that have been prescribed antidepressants are actually taking the antidepressants. And this is not just, these are data from the US, these are data from Europe. So medication adherence, it's a huge problem. Upwards of 30% don't even fill their medication when they're being prescribed. This, by the way, is not unique to antidepressant. It also happens for antihypertensive. It happens for hyperlipidemia drugs. So this is a very, very significant problem. And we looked at this for a while. There's been really no concerted effort in our field to really get to the bottom of what are the processes that drive adherence. People have studied it, but not to the extent that it really needs to be studied. The other element is that we did not include in this particular definition, maximizing doses. And we know from many medical records that that many patients are being subtherapeutically dosed with antidepressants. So that's another element. We did not account for in this group for psychotherapy or behavioral therapy. Part of that is it's difficult to find these codes in some of the healthcare data. It's getting better, but if you look at over the past, particularly if you look over the past 10 to 15 years, it's harder to find these codes explicitly. And then the other element is we don't, unfortunately, have data in the All of Us data set about early life adversity. There's now a new wave of assessments that were made that include some childhood trauma measures, but at the time that we were analyzing the data, that was not available. And we know that that has a huge impact on treatment-resistant depression. The way to think about the emergence of treatment resistance is you could look at the socioeconomic context, and that provides essentially kind of a risk assessment. If you're unemployed, low income, and if you have early life adversity, then obviously other groups have studied the lack of early response to treatment as one of the flags for treatment resistance. And then what I said before is you have a higher comorbidity profile in these people. So for a while, we've been thinking about, okay, so maybe what we need to do, can we figure out a way to predict treatment resistance before it emerges? And so that we focused on that for a while, but I'm going to tell you something I think that is important also for other areas. We kind of pivoted away from that a little bit, and I'll tell you in a moment why. The other nice thing that we were able to do with this is because the All of Us data has biological data, and we have these are genotyped individuals, we were able to look at the genetic architecture of treatment resistance. It has been done in other contexts, but this actually is one of the largest studies where we looked at treatment resistance. Again, this is our definition, and we are aware of some of the shortcomings. So we looked at polygenic risk scores in this context: education, cognition, personality, sleep, and temperament. We also looked at other components. So what I'm going to tell you a little bit about is what's the genetic profile of those individuals who develop treatment resistance. So what was surprising to us actually is that many of the psychiatric risk scores, say for depression or schizophrenia, did not show significant association of those individuals that developed TRD versus those that did not. We did find strong association with personality and sleep, and I'll show you this, and also with cognition. So one of the things that we looked at is both the neuroticism polygenic risk score, but also the symptom component-wise polygenic risk scores. These were developed a number of years ago by Mats Nagel based on the UK Biobank data. And what we found is that individuals with high polygenic risk scores on tenseness and lethargy, which are part of the neuroticism, but also the neuroticism that have high polygenic risk for insomnia and depressed mood, were also at higher risk for treatment resistance. On the other hand, people who had a high cognitive performance or high educational attainment polygenic risk scores were actually at lower risk for developing TID. And we tried to quantify this by dividing people into high and low strata. And what you see here is basically over time, from our first definition of first antidepressant use, from MDD diagnosis. And what you see is that it's basically three different lines. We have the low polygenic risk scores, the mid-range, and the high polygenic risk scores. And what you see is that those in the high polygenic risk scores are much faster to develop TID. So, and we've been doing some other studies with the All of Us data, looking at specific pathways, whether it's inflammatory or metabolic. But I want to shift now and tell you a little bit about the next stage. But before I do this, I want to tell you why we got to work on this and how we pivoted away a little bit from pure prediction. So I've been working on prediction for a long period of time. We've done some studies early on over 20 years ago now, where we tried to use brain imaging to predict relapse in a group of people with substance use disorder. And you know, you might argue today it was probably overfitting what we found, but we've been replicating this in various cohorts. There's a modest predictability of, if you use brain imaging, there's a modest predictability of identifying individuals who will relapse. But the number one question that we got, and over the years, and this has not changed, the number one question you get when you do prediction work is, okay, so you could predict whether a person, say, relapses, or a person has another episode of depression, or a person, God forbid, commits suicide. So yes, that's an interesting and important achievement. But then the question is, what am I going to do about it? And it becomes very clear to me, particularly over the last several years, that particular prediction of states, is actually not that useful, because it doesn't tell the provider what should I do about that state or that impending state. And this is where we start thinking about what is actually useful. What is useful if you can help identify actions that you can take that will make a difference in the person's life. And that's how we got into this counterfactual treatment optimization. So let me kind of set that up a little bit. This was this work that's being done by two computer science grad students. It's just can't do this without people who actually can do the coding. So what is the underlying problem? And we all know this. I mean, I've ran a mood disorder clinic for over 20 years. You have people that come to your clinic at various stages, and you're basically treat them with the tools you have available. Antidepressants, maybe neuromodulation, maybe cognitive behavioral therapy, maybe something more fancy these days. But the problem is you're doing educated guesses over time. And the truth of the matter is, what you're doing in your mood clinic rarely reflects what clinical trials actually tell you. Clinical trials tell you that if you take a group of people, you take them off their medications, you randomize them to, say, several different drugs, how they're responding to those drugs. And we know, there's a decent response rate and they're better than placebo. But we also know that many people don't respond. So the truth of what you're encountering in your daily clinical activities is very different. You're encountering basically a person moving through the system, being on various drugs, having various treatments. And what you're trying to do, at least that's what I was trying to do, is trying to make people as good as you can in some way, shape, or form. You prescribe different antidepressants, you change dose, you maybe enroll them in some kind of cognitive behavioral treatment or some other treatment. You identify whether they have comorbid substance use or drug use, and you're trying to address that. Then you worry about their medical situation, and maybe they have diabetes, and you have to control the diabetes. That's actually what you're doing on a day-by-day basis. And so, and much of it you do with some kind of basic knowledge of the process of what causes these things, but there's relatively limited evidence of what does one over the other. That's the situation. And that situation, from my perspective, maybe disagree, and I like to hear that. But from my perspective, that hasn't changed from when I was a resident to now. That's pretty much still the same thing. And so the hope that what we're trying to solve with this approach I'm going to show you about is, can we somehow optimize that process? And then, so let me kind of walk you through. So counterfactual treatment optimization is kind of, I know it's a fancy word, and I haven't come up with anything different, but it kind of encompasses what we're doing. Counterfactually, I'll show you what that means in a moment. But it's really an amalgam of three different areas that I've been interested in. It's essentially looking at statistical causal inference, and many of you probably know that the Nobel Prize in economics a number of years ago went to a number of different theoreticians who developed what is called the potential outcomes framework. And the potential outcomes framework is a way to formulate causal questions. And the easiest way to understand that is, okay, let's say you have a headache. And you have a headache, but you don't do anything about it. But then there is another you, that decides, oh, I'm going to take an aspirin. And the idea is that if the aspirin of that other you cured the headache, then the causal effect was the aspirin, because the person that didn't take the aspirin still had the headache. The person that did take the aspirin did not have a headache. Now, it's potential because you can't be both people, because you can't split yourself into a different world. What the potential outcome framework does, it creates a counterfactual based on data that you have available, and creates a counterfactual situation and asks the question, what happens if I create that counterfactual situation? And I'll explain what that means in our context. Now, the reinforcement learning, one way to think about it, as you are thinking in terms of the actions that you take with an antidepressant treatment, for example, you can think of that this can be described by three different parameters. You have the patient that is in a certain state, say that the person is depressed or the person is not depressed. You have an action, which is I give an antidepressant or prescribe an antidepressant or do ECT or I do TMS or whatever, that's the action. And I have an outcome, which is in a certain time shortly after I've done this, the person is either still depressed or not depressed, or So the idea now is what you want to know is what are the best state action outcome sequences, and you can learn this if you have data that inform you about this, and you can use reinforcement learning to do this. So that's the reinforcement learning part. And then, of course, you have the clinical workflow, which is essentially the actions and the states that you have available. So the one element that is still, you're still asking, so how do I create the possible person, the possible me that took the aspirin versus the real me that did not take the aspirin? And so this is the one element, actually, for this particular element, for this particular approach, it's the only element really that we use currently AI for. We used AI in a number of in the development steps, but practically speaking, one way to think about this is you want to create almost a mirror image of the person, except the person's doing something different, like me taking the aspirin, and that's a digital twin. The digital twin, the idea of the digital twin comes actually from engineering, and strictly speaking, we're not quite doing digital twins because the digital twins are really mechanistic copies of the original. The first term was used by NASA in the 60s when the NASA engineers had actually copies of the lunar module or the Apollo capsule on the ground, and were messing around on things on the ground to see what was going on in space. Because of course they couldn't directly mess around with these with the equipment in space, and that's where the term digital twin was born. But in that case, you have a true digital identical copy of the engineered system. So let me just now walk you through the different stages of how we do this counterfactual treatment observation. So the first thing that we do, we actually work with our local health system, which allows us to have really access to longitudinal, detailed data, both mental health and physical health, and we identify people with depression and their first antidepressant treatment. I misspelled that. First antidepressant treatment, which is our index date. So our index date is person with major depressive disorder who is being treated with an antidepressant. And then we basically collect all the prior information and we exclude people for this particular purpose who have psychotic disorder or bipolar disorder. That basically creates the cohort for us. And for that, we have basically built data structures that allow us to essentially say, okay, what's the person characteristic at any given point in time? So the next thing is we're creating a predictive framework. And there are a number of different ways how you can do this. And I'm sure you just one example. So what we did is we created 12 weeks period that were partially overlapping by 4 weeks. And we essentially identified what happened in those 12 weeks moving forward. So the way to think about this is you have the T0 index date that I talked about before, and then you look at 12 weeks, okay, what's happening over the next 12 weeks? And then we shift the window by 4 weeks and we're asking again. And we do this for the next 12 months. So that creates essentially the sequential predictive framework. Next is we have to so you can easily, so here's the one thing. You could almost immediately see how this could, the permutations and the number of different states, the number of different actions, in the combinatorics can blow up incredibly fast. Which means that you could almost say nothing, because you have, even with millions of data, you will not have enough to make statistically robust assessments. So we have to reduce the complexity somewhat, and therein lies some of the limitations of this approach. So I first identify various states that the patient can be in. The state is defined by a combination of EHR diagnosis, labs, medication, and essentially it helps us to sort patients together. The next thing is we have to define a restricted, limited set of actions. Because again, if you make too many actions, if they're too idiosyncratic, you cannot arrive at a robust estimate. And then lastly, we have to define a limited set of observed outcomes. The next stage is the actual counterfactual optimization. So the way to think about this now is that each state, each action, and each outcome changes over time, changes over the next year. And each of those triplets, the state, action, outcome, has a certain utility. These utilities are just numbers. And you, quite frankly, arbitrarily put a number to those states. Now, you can make these numbers actually more concrete, and I'll talk about that in a moment too. But you simply assign a value to different states. So, for example, and in this particular case, higher numbers mean poor state. So, as you can see in this lower right hand, let's say you have, lower number, you have a stable episode that has a utility of +5. An emergency room or inpatient stay has a utility of -10, and any kind of unplanned treatment change has another utility. Now, you may ask, well, how do you come up with these numbers? Basically, you make them up, is the short answer, and then you iterate over various utilities and see whether it affects the sequences that and the optimization that you observe. So this is basically one. But so what that means is that now each of the sequence in the end has a certain utility, and that is one number. And what you're trying to do is you're trying to optimize that number. Your goal is to say, I don't want large negative numbers in the future. I don't want an inpatient admission. I don't want an emergency room visit. I don't want to suddenly have to change medication. So the question becomes, how can I do this? And the way that the counterfactual optimization works, it asks the question, if I have patient X, and if I have comparable patients, which of those patients that are comparable at the beginning of the state had the best possible outcome? If they're comparable at the beginning, then I should take the action that is most likely to be associated with the best utility. That's basically what the counterfactual treatment optimization does. So the goal is to determine whether the observed treatment sequence is the best sequence. So in other words, whether what I saw with the patient that's actually I'm observing is the best, or whether there were any alternatives that were better. And what I basically showed you is the utility-based assessment, but we've also now done this with cost estimates, because you can associate a dollar number or to each of those outcomes, like say, what is the average cost for hospitalization? What's the average cost for a visit? What's the average cost for lab value you have to take? And then you can ask the question, okay, so over the next year, which one is essentially is the cheapest? That's one way to think about it. It's another way of doing utility assessments. So basically, we created the cohort. And I'm going to show you now a little bit of data for as a proof of principle. We initially created a limited number of exclusive actions. And we also imposed a hierarchy on these actions. So we had what we call optimize, switch, augment, therapy, which was any indication of a behavioral session or any somatic treatment. So initiate TMS or ECT. What we did is the actions were hierarchically organized so that a procedure became before therapy, became before meds, before continuation. So that allows us to sort actions into limited number of sequences. We did this, again, we've done it now with a number of different cohorts. This is a relatively small simulation with 500 patients. We've done it with up to 50,000. The results actually look similar. Obviously, the error estimates are much different, smaller with the larger cohorts. We further reduced the number of states that a person can be into 6 different states. So we call them S0 to S5. S0 is when a person who is depressed, who has a diagnosis of depression, but who at the current moment has no coverage. So what that means is it lacks current antidepressant coverage, or it was only evaluated but did not, for whatever reason, get treatment. We have an acute risk state where they had a recent emergency room visit, hospitalization, or crisis. And then we have, a patient with safety constraints, high complexity, comorbidity, low complexity. We basically order these states and these actions over time. Then we also look at what are the features that define these states that most likely contribute to the prediction of the sequences. So we have like demographics, the medication history, the number of different treatments, and the type of utilization. And then basically that allows us to assign different states to at any given points in those in the window that we define. As I said before, we used a fairly simple utility computation where we assigned a plus 5 utility to a stable state, a minus 10 to an acute emergency room or hospitalizations, a minus 3 to medication change or any safety issues. We also added penalties, and this now gets into the nitty-gritty of how you can actually compute these. The problem that you're facing is that these sequences, of course, are not equally distributed. You have some that are common and that are some that are less common. But the issue is that particularly the sequences that are less common, you don't want to prefer them if they're very rare, because you don't have a lot of confidence over those sequences, and therefore you impose an additional penalty. And then you essentially get an estimate. So the question now is, how do you actually know that this works? It works if once you identify all these different states, what you can do then is you can simulate these pathways, and you can ask the question: if I had followed this counterfactual treatment optimization policy, how much better or worse would I have done? You can do it in terms of utilities, and you can do it in terms of dollars. And that's basically how you know whether you're doing better. So, and you can also ask the question: if I had followed the policy, do I have a greater rate of stable periods? And so what we're showing here is that with this simulation, you actually get a high number of stable states, and you have better utility. The numbers are small, but they're significant. And then you can ask on average, do you actually save money? And on here you see that the distribution is highly uneven. We saw some positive signal on the mean, but nothing really on the median. This has to do with a number of different factors. The numbers of patients are still small. Obviously, our utility estimates, our number estimates vary from hospital system to hospital system. But I'm showing you this to say that in the future, with millions of the cases, you can easily quantify whether the counterfactual actually is cheaper than what you're actually doing. This is just another way of showing this in terms of the value advantage of the counterfactual. Here is in terms of the recommendation. So another way of what you want to learn about what drives the decision making of the counterfactual treatment optimization algorithm. And so you can ask the question, which are the factors that most critically change the counterfactual assessment? And here's a list of them. You can see some of these are pretty obvious. So acute service use history has a strong impact, medication burden, psychiatric diagnosis load, medication diagnosis load. These are factors we're all well aware of. The last thing that we are doing now is we're also creating stress scenarios. So that is now, what you want to know is, okay, so you built this model, this predictive model of what you should be doing over the next year. But you also want to know, well, how much better or worse is it if I stress the model? So we create various different scenarios where we basically stress the algorithm. A null scenario, benefit in a stress scenario. And what, I don't want to go too much into it because I'm almost out of time. But with this synthetic validation, we can see that the CTO is still better than, it still provides a residual benefit. So at least for now, there's some reason to believe that this clinical trial optimization algorithm is telling you something that could potentially be useful, that is robust, and that can essentially indicate how much cheaper treatment would be if you followed the other policies, and tell you which are the factors that influence decision making. So this will be my last slide. So basically what I talked about is we first started doing this electronic health record based research focused on treatment-resistant depression. And we used an operational definition of treatment resistance from the structural EHR data with all of its problems. We looked at the clinical and the genetic signature of these. And what I didn't tell you about, which is why I wanted to talk about this CTO stuff, we did a number of prediction approaches. It actually turns out that we encoded people with depression in various AI systems in a number of different ways, and trying to see whether the AI system can actually predict for us who's developing TRD and who doesn't. And the upshot of this is actually the vanilla AI systems cannot. We've tried that with multiple systems, even the ones that have been exposed to EHR data, and they cannot. We get a moderate prediction with standard machine learning tools, which is what other people are doing too, so that's not too surprising. But it's not great. So it's, again, what you find in general prediction. You can get an AUC of about 0.6, 0.7, which is better than chance, but it's not good enough for individual prediction. Now, with the counterfactual treatment optimization, essentially, from my perspective, it is still it's trying to predict something, but it's trying to predict something that helps you to think about what you should be doing. So it moves from predicting states, like Tier D, to predicting the best state action outcome sequences based on the data that you have available. It can be applied to structured EHR records. That's what I just showed you. As a proof of principle, it yields overall utilities and cost estimate. And ultimately, and in combination with AI systems, I think it has the potential to help the clinicians to make better decisions. Because eventually, what I'm hoping this will be developed into, it will be run by an AI system on all of the different patients within a system. It will make prediction within the system about these patients. We know that generalizing prediction is extremely difficult. In fact, I was part of a group that looked at this in clinical trials, and what we basically found is that you cannot predict outcomes from one clinical trial to another clinical trial. There are too many factors that are unaccounted for that make it very difficult to do generalizable predictions. But what we're trying to do here is doing very specific prediction to a very specific healthcare system with using EHR. Thank you.
Improve care. It's very difficult. And so are you saying that we should just let the AI decide and take it out of the hands of the clinician? Because that's one of the things that we may need to do in order to improve usual care.
Yeah, I think you bring up very valid points. In fact, actually, I would contend that this is exactly the adherence problem. Patients don't adhere to the medications and doctors don't adhere to the treatment algorithms. So we don't adhere to anything, right? So that's a big issue. And I just had a very interesting discussion with an implementation scientist, which I think is also something that is highly undervalued. I've been in the biological arena for a long time. And we come up with all these very, very fancy ways of measuring brain activities, doing this, that, and the other thing, hoping that this will tell us something. But then we don't go the last mile or the last kilometer or whatever. And that is exactly what you were saying, is that the average treatment quality is modest. Without being, but here's what's interesting, and I've talked to several people who do study in primary care, and what they found is, which it doesn't, is not too, it doesn't speak well of our discipline, but what they found is that in primary care, the primary care docs are much more willing to adhere to, say, a recommendation, because they know they don't know much about depression, or they don't know much about PTSD or anxiety disorder. So if they can briefly being explained, okay, here's what you should be doing for the next 4 weeks because of this, that, and the other thing, they'll do it. A psychiatrist might say, I know Joe. Joe needs this. He doesn't need that, right? I mean, that's big. And so what you bring up is actually, I think, a deep problem, and it's something that also needs to be studied and improved on an implementation science level, because we're essentially because we think we know what's best for the patient, which is, I'm not faulting that sentiment. Sometimes don't do the best for the patient. Yeah.
Thank you. Can everyone hear me? Okay. Thanks everyone for being here, and also for the opportunity to present on cultural adaptation of digital mental health interventions in global health. So today I'll talk about some of the methods that are being utilized, gaps in the literature, as well as future directions. So digital mental health interventions, such as mobile apps, are increasingly being used, and they are a compelling means to help address the treatment gap globally by expanding access to care, in particular for individuals who currently do not have access to care. So for instance, people who live in rural and remote communities, people from diverse ethnic and cultural backgrounds, those individuals who have additional barriers to receiving the care that they need. Current evidence shows that there are a lot of digital mental health interventions, but most of those are currently being developed in high income countries. There's a lack of digital mental health interventions being developed in low and middle income countries. So what is critical in this context is cultural adaptation. Cultural adaptation of the interventions to ensure that they are appropriate for individuals from diverse communities. And the definition is included there. Current evidence shows that there are increasing number of culturally adapted digital mental health interventions. Various adaptation strategies are being utilized. Most evidence out there focuses on feasibility and acceptability. And while there is emerging use of co-design and participatory methods with knowledge users, such as end users, providers, and community members, this isn't being applied consistently, and a lot of it isn't being done in a meaningful, engaging manner throughout the entire research cycle. So what I will be talking about in the next couple of slides is based on literature review across 4 domains: cultural adaptation, digital mental health interventions, mental health, and global health, and also informed by research that I'm currently working on with my supervisor, Dr. Mihalek, focused on cultural adaptation of an app for bipolar disorder research involving people with lived experience across 3 languages. There's various gaps in the literature right now on cultural adaptation. First, these are divided into 4 various areas. The first is methodological. There's currently no standard for cultural adaptations specific to technology. There's a lot of cultural adaptation frameworks that are available for in-person delivery, but because there's a lack of something that's standardized and consistent to be used for digital mental health interventions specifically, there is thus no consensus on what cultural adaptation means. And the second one is evaluation. There's a lot of studies happening, but there's few studies focused on effectiveness and also limited implementation outcomes. And then the third one is reporting, limited description of knowledge user engagement, and adaptation processes that are difficult to replicate. So again, that theme of like inconsistency across studies that are being done out there. And then the last one, is critical one, is around equities. There's underrepresentation of diverse populations. So already digital interventions are not being developed as much in low and middle income countries where the majority of the global population live. And then in instances where they are being developed, there's not enough engagement with people from ethnic and cultural backgrounds. And the last slide I will be talking about is opportunities and future directions. The important one first is around that equity piece. So strengthening co-design and engagement, enhance collaboration with knowledge users. So this really gets to the point of, well, if you want an app that is very usable for people, that people can engage with, and on a long-term basis beyond the end of a clinical study, then what do? Well, you try to engage the people who will actually be using these apps in the end users, to get a sense of what they feel would be important for them to help them in their journey and to increase their engagement. The second one is standardized adaptation and reporting. So this goes to the earlier gap of there's no standardized framework for evaluation, and recognizing how difficult it is to have a standardized framework because of digital mental health interventions and different contexts are so variable, so different. But if we start with one standardized framework that can then be adapted, perhaps there'll be more uniformity in cultural adaptation methods and processes. Third one is generate stronger evidence. So conduct research to gather more robust evidence. And this gets to how there just should be more research done involving people from ethnic and cultural minorities. And the third one is integrate cultural adaptation. So incorporate cultural considerations into implementation planning. So not just have the cultural adaptation work be an isolated component that is just something that people do to maybe check off something, but to really integrate it into the research, the entire research cycle, to ensure that it is done in a meaningful way and can be sustained. And that leads into the next one is focus on sustainability and scalability to ensure long-term viability and widespread adoption. So the cultural adaptation process is not just a single step. If you integrate it into the whole research cycle, then there's that essentially that foundation that can be then utilized moving forward to expand the cultural adaptation process to additional contexts. And then the last one is leverage technology, is utilize technology to enhance implementation. So a little bit just like utilizing technology to improve the future of cultural adaptation, to perhaps speed up the process, and to also recognize that technology sometimes can be a hindrance. So ensuring that it can, like, we are adaptable and can go both ways. So an example of that would be if the app format does not work for certain individuals, perhaps in rural communities where there's low bandwidth connection, then we can develop a low bandwidth option, maybe via the web or in-person delivery, but just recognizing that there needs to be flexibility in the cultural adaptation work that is so critical for improving global mental health.
Great, thank you so much. So our next speaker is Sydney Saint. Sydney is a PhD student in Dr. William Panenka's lab, and she'll be talking about brain white matter integrity after non-fatal opioid overdose.
Thank you. So the aim of the work that I'll present is to index changes in brain white matter health associated with non-fatal opioid overdose, which at greater severities plausibly represents hypoxic brain injury, and there may be structural and cognitive consequences. This is a retrospective pre-post overdose propensity matching design using group by time interaction terms to test for overdose associated or differential change in a group of participants who experienced an overdose between brain MRI scans. The data source for these analyses is a hotel study from the psychiatry department, led by Drs. Honer and McEwen, a cohort study of health in marginally housed residents of Vancouver's downtown core, which is pictured on the slide. And as part of this study, which ran for 15 years up until about a couple of years ago, participants attended serial structural, including diffusion-weighted brain MRI scans, and also could regularly self-report opioid overdoses. 30 of over 400 participants had usable diffusion-weighted brain MRI before and after a non-fatal opioid overdose in less than 5 years between scans, and they were propensity matched based on age, sex, Charlson comorbidity score, and frequency of non-prescribed opioid use before both of their scans to 30 other hotel study participants who did not have a self-reported opioid overdose between their scans. Permutation analysis was performed on skeletonized fractional anisotropy, or FA, which indexes the coherence of water diffusion along brain white matter tracts, and typically is conceptualized as an indicator of white matter health, as well as on MD, or mean diffusivity, which indexes net or isotropic water diffusion along brain white matter tracts, and typically is considered an indicator of brain damage. And we ran group by time weighted contrasts, which were the most of interest in order to examine differential change in FA or MD, and therefore possibly differential change in white matter health across scans where participants overdose between them. And then so to frame the results of the group time interaction contrast, some first results are on the bottom panel of the screen. On the left, it shows that despite my best matching efforts, there were group differences in FA at baseline, such that generally the reference group had higher FA or healthier brains. And then on the right, you can see in the red regions, there were widespread decreases in FA across scans for participants who had an opioid overdose between them, and where there were no significant changes observed in the reference group. And then the results for the MD contrast aren't shown. However, the reference group didn't change across scans, and the overdosing group had somewhat distributed increases in MD on the right side. And at baseline, there was one region where the overdosing group had higher MD in the subthalamic region. And the results of the group by time-weighted contrast showed, first of all, that there were no differential changes in MD across scans, but pictured are the results of the group by time-weighted contrast of FA, which suggested overdose-associated decreases in FA in regions including the corpus callosum, corona radiata, right posterior thalamic radiations, right internal capsule, as well as some of the left cerebral white matter. And then last, in exploratory analyses, we examined whether processing speed changed in the overdosing group using cognitive assessments from the hotel study that bracketed the overdoses and that bracketed for the reference group the midpoint of the MRI scans. And we ran a mixed effects model with a group by time term of interest to test for overdose-associated change in processing speed, and these scores are from the Stroop assessments, and the results did not indicate that there were overdose-associated decreases in processing speed. To summarize, I think this is some of the first neuroimaging work focused on overdose effects on the brain with both pre- and post-overdose scans to appropriately index change. Most of the other research in this area is from case reports. And our analytic results are suggestive of overdose-associated deficits to brain white matter integrity as indicated by FA without corollary decreases in processing speed.
So our next speaker is Dr. Ellen Cornish. Ellen is an associate physician at Redfish Healing Center, specializing in complex mental health and substance use.
Good morning, everyone. I am Ellen Cornish. I'm an associate physician at Redfish Healing Center, and I'm going to talk today about integrating repetitive transcranial magnetic stimulation, RTMS for short, alongside psychosocial interventions in a population with severe concurrent disorders. Redfish Healing Center is an inpatient tertiary provincial program which treats patients with the most severe concurrent substance use and mental health issues from across BC. BC has the highest rates of overdose death in Canada, and our patients at Redfish were found to have an average lifetime history of overdose history of 7 to 8 overdoses, and they are complex to treat. They're at an increased risk due to the potent unregulated opioid supply and contaminated stimulant supply. And as you can see on the graph on the right, apparent stimulant toxicity deaths in Canada overall are on the rise. Currently, we have opioid agonist therapy for opioid use disorder, but no approved pharmacotherapy for stimulant use disorder. Despite the built-in psychosocial interventions at Redfish, the harm reduction strategies and the addiction stabilization services, our patients remain vulnerable from persistent substance use cravings, emotional dysregulation, relapse, and overdose. In patients with severe concurrent disorders, the convergence of trauma, impulsivity, emotional dysregulation, and substance use suggests dysfunction within the prefrontal striatal limbic networks. RTMS uses magnetic pulses to stimulate nerve cells in these areas to balance mood and reward systems. And it's thought that strengthening cognitive control through brain stimulation helps reduce craving intensity and relapse in substance use disorders. It is non-invasive, usually with only minimal side effects like a mild headache, and it doesn't increase the patient's usually already high medication burden and interactions. We started an RTMS program last spring where intermittent theta burst stimulation was directed to the left dorsolateral prefrontal cortex at 80% of the resting motor threshold. And you can see that being demonstrated there in the photo, which is taken from our RTMS room at Redfish. The patients receive 3 daily treatments. Each one lasts for 3 to 5 minutes, and they do this for 10 days for a total of 30 treatments. Traditional RTMS treatments would take around 40 minutes, but with this accelerated protocol, there's less impact on patient routines, and they're more likely to complete the full 30 treatments. So far, 16 out of 22 patients who started RTMS have completed the full 30 sessions, and the emerging outcomes are reduced stimulant cravings and overall improved motivation, executive function, and ability to participate in other programs offered at Redfish. No serious adverse events have occurred, and failure to complete treatment has been multifactorial, including things like sudden personal grief. RTMS is currently Health Canada approved for major depressive disorder, OCD and smoking cessation, although emerging evidence suggests it may be an exciting, innovative therapy for substance use disorders, which doesn't increase pharmacologic burden or significant side effects. To summarise, by functioning as a neurobiological stabiliser, RTMS may offer a safe, non-invasive treatment or adjunct for patients with substance use disorders. By targeting brain reward systems, impulsivity, and strengthening cognitive control, it may reduce cravings, relapse, and overdose risk. Thank you for listening. I'm happy to answer any questions you may have at the end.
So our next speaker this morning is Joel Rivera. Joel is a master's student in Dr. Lynn Raymond's lab.
So hello everyone. Today I'll be discussing part of my project called paravalbumin interneuron irregularities and Huntington's disease. So for those that don't know, Huntington's disease is the most common inherited adult onset neurodegenerative disorder. It is marked by symptoms in movement, and mood, cognition, and motor symptoms, caused by mutations in the Huntington gene, CAG repeat. And previous work from our lab has shown in mouse models a sensory spread phenotype in Huntington's disease, which is basically in voltage-sensitive dye imaging, as you can see on the panel on the bottom, it anesthetized mice in response to a sensory stimulation's exaggerated spread of cortical activity relative to the wild type that you can see on top. So this really hints towards changes in cortical excitability. And in the bottom, you can see kind of a follow-up looking at intrinsic properties of cell types in the cortex. And we really see kind of the confirmation of this increase in excitatory postsynaptic potentials on the left, inhibitory postsynaptic potentials in the middle, and overall an increase in excitatory to inhibitory inputs in these cells. So this kind of hints towards looking at cortical interneuron GABAergic subtypes. Particularly, we chose to look at PV interneurons. It's the most prevalent subclass, and they synapse, as you can see on the right, directly onto the soma of the cortical pyramidal neurons, really serving as gatekeepers of excitatory inputs in these cells. They're also required for proper cortical sensory motor processing. So really the hypothesis is that there's some kind of irregularities or deficits in this interneuron subtype that we can see in Huntington's disease, kind of resulting in the changes in EI ratio. So when we do an immunological stain for paravalbumin and look at the PV positive cells in the cortex of the Huntington mice, we can see on the left that at pre-manifest, so as early as 3 months, there's reductions in the visual cortex in layer 4, and it really kind of progresses to all layers in the visual and sensory cortex on the right at early manifest, so 7 to 9 months. So to verify these results, we also did Western blot, and as you can see, the changes in visual cortex are consistent, so reductions in bulk expression of paravalbumin, and also in the visual and sensory cortex. So the differences are quite striking, as you can see in the representative image. So what's going on really? Well, recent work has shown that neuronal activity is really key to regulating the gene expression and differentiation of these cells. So they possess really unique adaptations for a fast spiking behavior, particularly perineuronal nets and this Kv3.1, which is a potassium channel predominantly expressed in these cells. So really, why does this matter? Well, as I showed in the beginning, the changes in cortical excitability kind of hint towards a reduction in the activity of these cells. So we would expect that the changes in paravalbumin expression in PZ positive cells, as well as similar changes in Kv3.1 and PNNs at later stages of the disease. So future work would explore kind of the potential of increasing the activity of these cells pharmacologically to see if we can do or rescue changes in the Huntington phenotype. Thank you.
Thank you, Joel. Our next speaker is Dr. Nicholas Ainsworth. So Nick is a geriatric psychiatrist and clinician scientist working at Providence Healthcare.
Thanks, Dr. Beasley. All right, can everyone hear me okay? Good, okay. Hi, everyone. So I'm really excited to talk to you today about some findings from the LL-DOPA trial, which is a pilot feasibility trial, Health Canada regulated phase 2A pilot feasibility trial looking at measuring the psychomotor response to levodopa or L-DOPA in late life depression. Oh, I see. There we go. So this is just, and condensing this into 3 slides is always a fun challenge. So I'm going to be speaking a lot outside of the slides, but I want to call your attention to this is the schematic of the study as we talk about the rationale for this study. So it came out of a series of related questions that are still unanswered or underanswered in late life depression. So one of these is, it's a very heterogeneous condition. So the question is the underlying neurobiology, the endophenotype of late life depression, one or is it several? And there's not a consensus, but I think most people suspect that there's probably more than one endophenotype at play here, and there are different trajectories that people follow, especially whether or not they develop dementia. So the question of interest was, well, what's underlying that heterogeneity and what's underlying those differences in endophenotypes? One candidate is dopaminergic function. So we know that psychomotor slowing is really common in late life depression, but it presents variably to varying degrees depending on the severity of the condition. And there is some evidence, especially preclinical and a little bit of early clinical evidence, that suggests that dopaminergic dysfunction underlies the difference in intensity of psychomotor slowing and psychomotor dysfunction. And it may also underlie some of the cognitive function heterogeneity in the condition. So the question then became, okay, well, can we modulate the dopamine system in some way to try and get at this heterogeneity and to be able to classify those who suffer from late life depression into different categories or along a dimension related to their level of dopaminergic dysfunction and how reversible that is. And so the tool being used is levodopa, which you may know from Parkinson's disease is the first-line treatment for bradykinesia, which is also a type of slowing, but related specifically to dopaminergic cell death in the nigrostriatal system. And here, we're not sure if we're dealing with, actual neuronal death, but we're dealing with a hypofunction of the dopamine system. So what we've done is taken participants with late life depression and at baseline done a whole battery of tests, depressive symptom questionnaires, the NIH Toolbox cognitive battery, and also some measurements of psychomotor speed, including gait speed with the 4-minute walk test, and also the CORE, which is a clinician-rated measure of psychomotor slowing. And then we've given them levodopa for 2 weeks, 150 milligrams once a day for 1 week, and then twice a day for the second week, spaced 4 hours apart, which is similar to what a preliminary trial clinically would be in Parkinson's disease. And then 1 hour post, when we suspect most people will have basically a peak effect of the drug, after the 2-week mark, we recheck all of those measurements. And then we run people through clinical treatment, which is not protocolized, but it's based on established guidelines for treatment of late life depression. And then the plan eventually is going to be to see how good someone's degree of psychomotor response to levodopa was at classifying their likelihood of responding or not to a dopaminergic antidepressant. So these are some of the key findings so far. We're a little bit past halfway in recruitment, and this is the results from the first 13 participants, 12 of whom were able to complete the full challenge. And I want to call your attention to a couple of things. So one is that we did see a significant biological change or clinical change in several different measurements across those different measurement categories from pre to post challenge. But the second, as you can appreciate, especially if you look at things like walk speed and list sort and also the MADRS, is there does seem to be a heterogeneity of response and maybe even some clustering that's happening. And this is what we were hoping to see, because that suggests that maybe there is in fact a dimensionality to someone's degree of psychomotor response that tells us something about their underlying condition. Most importantly and most surprisingly, a majority of participants got some improvement in their depressive symptoms, even in only a 2-week period, which was surprising and cautiously encouraging. And in fact, 41% of them met a 50% reduction response criteria, and 17% even met remission criteria, according to the MADRS, which was very surprising. And then you can see that most participants, but not all, got some improvement in walk speed and psychomotor slowing. Working memory really seemed to split the field in half. And we did not see an improvement in processing speed, which suggests that maybe that's not as exclusively dopaminergically driven in this population as we thought. So what are the takeaways from this? So this is the first investigation of levodopa as a challenge agent in late-line depression, and it's going to be some of the first clinical data using levodopa as a clinical treatment or tool in older adults with a depressive disorder as opposed to a movement disorder. The challenge was very well tolerated. So this was really encouraging. Almost everyone completed the study. We did have to do some flexible dosing where we decreased the dose and then titrated it up more slowly, mostly in response to nausea as a side effect. And we didn't actually see any hypotension. So we didn't see any blood pressure instability or drops associated with levodopa, which is a Health Canada area of concern for this drug, but it seems like that's something more specific to the Parkinson's population, probably because of the autonomic dysfunction inherent to that disease. And then I finally wanted to say, again, this clustering of clinical effects is really interesting and juicy, and that's something we want to dig into more, but we're going to need a larger study for that, probably a follow-on randomized clinical trial with a larger sample size after we submit this pilot data for grant funding. Recruitment is ongoing at St. Paul's Hospital and Mount St. Joseph Hospital, and we're running our study clinically at St. Paul's, and I'm grateful to the department there for their support with some of the infrastructure that we've had to build for this study. So I'll just leave it there and say thank you very much for your attention and happy to answer more questions. I also have a poster in the hall. Thank you.
Okay, I'd like to invite up our next speaker, Stephanie Tedesco. And Stephanie is a PhD candidate in Dr. Christian Schutz's lab.
Hi, everyone. So I'm Stephanie, and I'm part of the Brain Lab here at UBC, led by Dr. Christian Schutz, and I'm excited to be here with you all today to talk about some of our recent work in concurrent disorders with childhood trauma and inhibitory control. So as we know from the literature, childhood trauma is a major risk factor for the development, severity, and also treatment outcomes for mental health and substance use disorders, including where they co-occur in concurrent disorders. And growing evidence has shown us that childhood trauma is linked with worse response inhibition. So this is a core executive function involved in suppressing more habitual or automatic responding. And this has been shown in healthy populations, substance use populations, and mental health populations, but it's not been looked at in concurrent disorders yet. So with that said, we wanted to look at the relationship between childhood trauma and inhibitory control in concurrent disorders. So this data is part of a larger study in concurrent disorder in patients at the Redfish Healing Center. As Dr. Cornish mentioned a little bit about Redfish as well, it's a 105-bed treatment facility in Coquitlam for patients with severe co-occurring mental health and substance use disorders. Within 30 days of their treatment admission, they did a response inhibition task as well as a childhood trauma questionnaire. And for the response inhibition task, this was developed by Sebastian and colleagues, a group in Germany. And essentially, it combines 3 classic response inhibition tasks. So a lot of you have probably heard of or used some of these, but the Simon or interference task, the go, no-go task, and the stop signal task, which measure interference inhibition, action withholding, and action cancellation, respectively. So the way that they combined all of these was there's a fixation cross and then an arrow that shows up on either side, and the participants are instructed to press a left or right button depending on which way the arrow's facing. And then when the circle is blue, they're told not to respond at all. So in the congruent trials, the arrow is on the same side that it's facing. So the arrow on the right side is facing the right side, the arrow on the left side is facing the left side. And then in the interference condition, we have these incongruent trials where the arrow is facing the opposite way. So it'll be on the right side facing the left or on the left side facing the right. And basically this tests interference inhibition because it's assessing someone's ability to suppress a distracting or competing stimulus. And the outcomes for that were reaction time for incongruent trials, and then also the interference effect, which is the incongruent trial reaction time minus congruent trial reaction time. All right, moving on to the no-go. The participants will see a resting state cross followed by a blue circle, which just indicates to withhold their action altogether. Pretty straightforward. The outcome for that is just percentage of correct trials. And then finally, we have the stop signal task where the arrow will come up and then the circle will turn blue after a variable delay or the stop signal delay. So this is measuring their ability to cancel an action once it's been initiated. And for this, we have the stop signal reaction time and also percentage of correct trials. So I know there's a lot going on here, but it's really nice that we get all of these outcomes in one task and the participants don't have to complete 3 separate tasks. This only takes about 10 minutes. And then finally, the childhood trauma questionnaire, which is a 28-item self-report, including subscales of physical, emotional, and sexual abuse, emotional neglect, and physical neglect. And each subscale has 5 items that are summed on a scale of 1 to 5 from never true to very often true. All right, so what did we find? We did a linear regression with all the CTQ subscales and all the HRI outcomes. And what we found was that physical or higher scores of physical abuse, sexual abuse, and physical neglect were associated with slower reaction time on the incongruent trials. So that's that interference condition where the arrow is facing the opposite way. And then in the physical neglect subscale specifically, we also see slower reaction time on stop signal trials, as well as slower reaction time on congruent trials, so a general slowing of reaction time in general. And so overall, these results are in line with previous literature that suggests that childhood trauma may adversely affect inhibitory control in concurrent disorders, particularly with physical neglect, as we see here, that have the most results. However, we didn't see results for the go, no-go task, the action withholding, and also for stop signal, only one of the subscales was significant. So further research is needed to replicate these findings as well as determine whether these effects extend to other cognitive domains. Thanks for listening.
So our final speaker this morning is Dr. Daniel Vigo. Daniel is an associate professor with the Department of Psychiatry and the UBC School of Population and Public Health. He's also the Chief Scientific Officer for Psychiatry, Toxic Drugs and Concurrent Disorders, and the Regional Lead Psychiatrist for the Assertive Community Treatment for the province of BC.
Hello, everyone. For a change, today I'm not going to talk about the work that I'm doing for the province, but I'm going to focus on a project that we're doing here, that my lab is doing here. Is the incidence of depression in people receiving monoclonal antibody medications for autoimmune disease in British Columbia, Canada, a population-based cohort study. So, biologics are drugs manufactured in living cells used to treat diseases like cancer, diabetes, autoimmune diseases, and their potential for depression has been suggested but not fully studied at the population level, which is what we focused on, examining their effect on incident depression in individuals with autoimmune disease. We did a retrospective population-based cohort study with province-wide data with British Columbians 15 years and older, with at least one autoimmune disease and no recent history of depression or biologics prescription. We follow them since their first biologics dispensation to their last, including lead-in and lead-out periods between 2018 and 2022. And the primary outcome was the incidence of a depressive disorder. We used latent space cohort matching, including 108 variables to balance the treatment and control groups, and then multivariate Cox regression to examine the association between receiving the biologics and developing depression. And we controlled for things like the autoimmune disease profile, comorbidities, severity of illness through various health records, through health encounters, profiles, use of antidepressant medication, COVID testing, vaccinations, age, sex, etc. And that is the flow of individuals, 310,000 people in BC with autoimmune diseases, excluding the ones who had past biologics use or depression, then looking at the ones that had received biologics, matching them with controls, and following them up for the same period of time in both cohorts. Our findings: there were 10,275 subjects exposed to biologics. We matched them with participants with similar covariate profiles, and incident depression was found to be significantly less likely by almost a third in subjects receiving biologics. Sorry, let me advance. In subjects receiving biologics with a hazard ratio of 0.69, with using a lead-out period of 30 days to account for the effect of the medication. And we did a bunch of sensitivity analysis before and during COVID, different medication use, different covariance combination, and they all showed the same findings with minor deviations in hazard ratios. To our knowledge, this is the first study to assess the effect of treatment with biologics for an autoimmune disorder on incident depression at the population level, and they appear to be effective in suppressing incident cases of depression. Our findings, plus the previous research that suggests inflammatory pathways in the development of depression, support further study of pharmaceuticals that may directly impact inflammatory pathways. And this is the work of my team and came out of a collaboration with Dr. Yatham, the head of the department. Thank you very much.
Okay, so I'd like to invite all of the speakers down to take some questions. You have a question online?
I believe the question is for Dr. Ellen Cornish. Our online participant is asking, has RTMS been investigated for opioid use disorder treatment?
I don't know if it's been investigated for opioid use treatment, but one of our upcoming research projects is to look at, so we investigate the craving severity as they go through their TMS treatments. We look at it at before treatment at session 10, 20, and 30, and see how their symptom severity and frequency is evolving. One of our upcoming projects is to look at which substances does it seem to help with most, and that will include looking at opioid use, stimulant use, cannabis use, and other things as well.
I have a question for Dr. Rivera, the person who did a presentation on Huntington's disease. I don't know much about Huntington's disease, so it's your opportunity to educate me as well. So you highlighted the significance of the interneurons, the parvalbumin interneurons in the disease, and you thought that they could be a target for rescue medication, correct? So these interneurons really have to do a very complicated computational job in kind of balancing excitation and inhibition within the brain generally, cortex and cerebellum. How do we fine-tune them with rescue medication? How do we know not to go overboard, for example?
That's a good question. Something that I didn't show was I showed the effects on the cortical pyramidal neurons, that there was reduced excitation, and also I didn't show they were firing less action potentials, but we also looked at, in that same study, the fast spiking interneurons, so the parvalbumin interneurons, and we saw that they had reduced excitation, they were firing less action potentials. So it's more so a matter of they are less likely to fire action potentials. The mechanism by which we would increase their excitation would be to, I guess, not to get too technical, but I guess it's just increasing activity in a sense that it's decreased. How to not go overboard. It's a positive allosteric modulator, so it wouldn't necessarily be increasing the activity, but if there is less current flowing endogenously and they're excited, it's going to kind of compensate for a lack, if that makes any sense. Maybe I'm not vocalizing this correctly. It's kind of, it's not exactly exciting though. Yeah, it's increasing the current.
Yeah,
if
but
it's
you see,
decreased.
the interneuron spiking may be because the different kind of signals do not converge coherently over time. Yeah, so it affects the way it responds to the integration of the different neural signals.
Yeah.
Rather than an inherent problem that we can fix at that site.
It's
That's
true.
what I'm trying to say. Yeah.
Yeah.
So a question for Dr. Vigo, Daniel. It's years ago when we were doing like interferon treatments for multiple sclerosis, we were very worried about depression risk because you saw terrible high rates of depression in treatment of hepatitis, right, with interferons. But we didn't see that in the MS world, despite it being a CNS variant of the drug, interferon betas, I should say. I'm curious, in your data set, were you able to stratify based on the condition that was being treated for that monoclonal antibodies? Because I can imagine could be quite different from, between inflammatory bowel disease to systemic lupus to, say, multiple sclerosis.
We didn't stratify. We controlled for various profiles, and we matched based on profiles. So there were suggestions about stratifying, and it is something we can do. In this case, it's not stratified. It's both in it's included in the variables that are used for matching, and it's controlled for the block down.
Okay, question for Sydney. Let's see. So you didn't see much of a change in processing speed, I guess, when there was an overdose between scans. But I'm wondering, could you further subset the data based on, I guess, how significant the overdose was? Like, how long, I don't know, before they were resuscitated, what their, I don't know, oxygenation was, or some like kind of ER type stats,
That would be nice, and I'm hoping to link some ED data to the data set, but these were self-reported and we have very few indices of how severe the overdose was. So within this, for these results, not really. Does that answer the question?
Sure. So there wasn't, I guess EMTs didn't, provide any notes. It was just like their, I don't know, maybe colleague like injected them with Narcan or something like that.
Yeah, so the data set is self-reportive receipt of naloxone from the timeline follow-back method, or via a semi-structured interview, self-reportive having gone to the ED, not necessarily being admitted for an overdose.
So this question is for Dr. Chow. I was very interested in this app that you're looking at, but I also thought that this is an ideal situation to use community-informed research. So what I was wondering is, do you have like a community board of potential users that give you feedback in developing it? Because it seems like you don't want to necessarily develop that in isolation with getting active feedback from folks.
Thank you for that question. There's multiple phases to the app development, and the app itself is called Polaris, and it's an app for bipolar disorder that my supervisor, Dr. Erin Michaela, has developed. And the development of the app itself took over 2 years, and that involved 2 different types of advisory groups. And one advisory group was purely people with lived experience. So that was the initial app. And now the cultural adaptation phase, we're culturally adapting it to 3 additional languages for an upcoming RCT to be conducted in North America, so Canada and the United States. That cultural adaptation process, 3 languages, French, Spanish, and Chinese. We are involving 3 advisory groups and people with lived experience familiar in those 3 languages. So the whole process has been from the initial development to where we currently are, filled with just really, really informed by feedback and input from advisory group members who are very, very much engaged. So we conduct meetings with the different advisory group members, maybe on a bi-monthly basis. And so the people who were involved in the development of the initial, the app, they are still involved in the ongoing process. Thank you.
This is for Nick Ainsworth, Dr. Ainsworth. So that was really interesting about late life depression and that L-DOPA might be a therapy. So I'm just wondering, and we know in Parkinson's disease, especially as people are older with Parkinson's, there's a very high rate of depression. You think it's the VTA is involved? Is there some overlap in the pathways in those two that L-DOPA may be helping.
Thank you. Yeah, I mean, that's one of the big questions that I have. We don't have any data about whether dopaminergic modulation of, for example, the striatum or various pathways in the striatum is affected by levodopa administration in depressed older adults with psychomotor slowing. We know that there is dysfunction measured in people with untreated late life depression, and we know that they're having a psychomotor response. But what we don't know is, whether there's a mechanism within the striatum that underlies it. And my big curiosity is exactly that. Is there some element of a common pathway that unifies or at least overlaps between bradykinesia in Parkinson's disease and psychomotor slowing in late life depression? And if there is, it might explain mechanistically why levodopa is having a clinical impact. So that is an unanswered, but I think very salient question that I would like eventually to be able to investigate with this sort of trajectory.
This is a question for Miss Stephanie Tedesco. Were there any sex differences found?
We haven't looked at sex differences yet, but that'll be the next step, is adding things like that.
So I'll ask a follow-up question to Nick. So Nick, as you know, I suppose over the past almost 30, 40 years, I think the field has used various tools to investigate the role of various monoamines in depression, right? And of course, you're trying to focus on dopamine, which is obviously interesting, although the findings in terms of some of the basic investigations have not yielded any consistent role for dopamine. But leaving that aside, just look at your study. As I understand it, you're using levodopa as a challenge and looking at the response to predict response of those individuals to dopaminergic agents, right? So
that's correct, yeah.
So I guess my question is, just trying to understand, in your study then, you're measuring the responses following levodopa administration, but as an extension, are you actually administering or randomizing these subjects to, let's say, a dopaminergic agent or something like serotonergic agent to really tease out, if you showed response to L-DOPA, you're more likely to respond to, let's say, something like bupropion versus escitalopram or something like that. Is that part of the study or not?
So it is informally the strategy for eventually sort of securing Health Canada approval and making the actual experimental phase, as it were, as streamlined as possible. We focused on the challenge phase. Everything beyond that is clinician discretion because it's a pilot study. But the goal is very much to have a follow-on larger sample that's randomized, where initially the effect of the challenge or the results of the challenge doesn't enter into it, but you're looking at, just by chance, those who get randomized to the dopaminergic drug, do they do better? And do you see some post hoc, when you're looking at it, some classification of likelihood of responding to, say, aripiprazole or bupropion based on the profile of their psychomotor response to levodopa? That's going to require a larger data set. This step was to establish the feasibility, make sure that it's well tolerated, and establish that there is some clinical effect to measure that might actually stratify individuals. And then the next step very much would be to actually have a randomized component with two separate augmentation strategies, most likely, and then to examine the correlation between, basically to sort of further classify the biomarker, their psychomotor response and their clinical response to a dopaminergic versus non-dopaminergic agent. Yes.
Got another question for Dr. Saint regarding the hotel study and the anoxic brain injury. I guess it's not a surprise that we're going to see fractional anisotropy changes and tractography changes in anoxic injury. I guess the question for me is, given that you are specifically looking at that population of toxic drug overdoses and opioids, was there anything unique in the pattern of the white matter change compared to, say, somebody with anoxic brain injury after drowning or, carbon monoxide poisoning or something like that? Is there anything unique about that pattern, or is it just a general picture of anoxia?
I don't know if I have a good answer for that question. I don't see any pattern that is necessarily distinct from the changes in FA that are shown after other hypoxic and hypoxic ischemic injuries like stroke and carbon monoxide poisoning, which often have shown like lower FA within the centrum semioval region, and there is some concordance there. No, to answer your question, I don't think so at this point.
Yeah, no worries. I mean, you've got a good population there of 30 cases, so it would be neat to wonder whether there's any changes in like the hippocampus or cerebellar area or basal ganglia.
Oh, sorry. Yes, volumetric. Sorry, in terms of volumetric analysis, it does look like there are decreases in the volume of the hippocampus when we're looking at the T1 weighted scans, which is still concordant with the pattern that would be expected for generally hypoxic and hypoxic ischemic injuries.
Question for Daniel. I was interested that you were going down the route of maybe kind of inflammation, or that the biologics were, I guess, interacting with the immune system. But is there also a phenomenon where somebody has a chronic illness that it might actually be protective against depression or manifestation of it because they're, I don't know, maybe so focused on that illness they don't maybe recognize some of the other attributes?
I can't think of any chronic illness that would be correlated decrease risk of depression. I have colleagues here that are more expert than I am on just reverse them, and we'll put that up. What I know is these disorders are correlated with higher risk. And in general, it's true across the board for chronic illness.
That doesn't mean like that they're being always persisting. Fair enough. They just get always. Whether it's
right. That
you could say.
So that's another very important point to make. This is all administrative data. So this is not true incidence. This is treated. So we're only capturing folks who actually show up. Someone writes down the diagnosis. Right. So what's happening in terms of true incidence is a layer farther in.
Yeah, and sorry, just one follow-up question. So with the decreased incidence in people who received biologics, can you disentangle whether it's just that they had more improved, like greater improvement in their physical status as opposed to people who did not, or whether it's specifically that biologic? Oh, you did. Okay.
Whole profile of visits to physicians, to the ED. We control for that in as much as we can control for that with administrative records. So they have a very similar profile of interaction with the health system that can be taken as a proxy for severity, acuity, or. In fact, one thing we did see is that for those that had more visits, so one could assume, conclude higher acuity or more severity or poor management of physical symptoms, there was increased incidence of it, right? Then we, as a control.
Maybe a quick question for Mr. Tedesco. I was kind of intrigued by the fact that you, in your task, which is kind of an interesting combination of different tasks, you see the main effects in the interference condition, not in the inhibitory conditions. The interference is probably more like, it could be lots of different things, but maybe more executive dysfunction rather than inhibitory dysfunction. But what do you make out of the selective finding that you're seeing the effects, particularly with mostly physical abuse and physical neglect with the interference condition?
Yeah, it's a great question. And looking at the literature and the reviews, you just see general response inhibition outcomes, right? And this HRI task has only been used by a handful of researchers. So usually it's not being, directly compared, these subcomponents. So I'd be interested in going through the review papers and taking out the specific tasks and seeing which ones are positive, which ones are negative, because it might be the case in the broader substance use literature that there's not as many results with those inhibition tasks and maybe more with interference. But as of now, I can't say, but I'm interested in knowing that as well.
I had a question for Dr. Ainsworth. That's kind of like a follow-up, but
from my as a bit more limited understanding, when L-DOPA is used in Parkinson's, in more long-term cases, there's issues with like efficacy when it comes to like tolerance, and then changes in dosage and whatnot would be needed. Do you believe, or from your understanding, your studies, do you think that might also be seen when using L-DOPA for depression? And then are there other, let's say, more longitudinal studies in plan to like take a look at that and those effects?
Yeah, that's a fantastic question. It is specifically not one that this study can answer in and of itself because it's a short-term 2-week trial. So I don't know. I think that's certainly a concern in Parkinson's populations. You might be aware, right? You get things like dyskinesias that can develop over time. You get eventually declining efficacy, which we think is a byproduct of the disease itself advancing, in terms of the neurodegenerative process. And we don't think that's at play here in depression, although perhaps there is something akin to that that's part of the picture. So that's really the question. What is the long-term tolerability? I think I would start by saying that I would not assume the long-term tolerability and efficacy in any way mirrors Parkinson's, because so far what we're seeing is a very different side effect profile. For instance, for example, much less hypotension in response to levodopa. So based on that alone, that would sort of falsify the assumption that it's going to look like Parkinson's in terms of long-term treatment, but it's an unanswered question. If it was going to be an effective treatment on its own, for instance, we would have to see whether or not an individual can tolerate it without developing tolerance or dopaminergic side effects like dyskinesias and impulse control disorders in the 6-month, 1-year, 2-year period. Absolutely.
I'll just make one more comment about that inflammation story that Daniel presented. So I think from what we know, most psychiatric conditions and many physical illnesses are associated with increased inflammation. And I guess what we don't know is, what is its role for those illnesses? Is it just an epiphenomenon, or does it have any causative role? No one knows, right? And I think for a number of years, there was this expectation that somehow adding some of the anti-inflammatory agents to antidepressants might actually improve the efficacy of these agents. But I think the field is now beginning to converge towards a direction where maybe a small subgroup of patients with the mood disorders may have significant increase in inflammation, which might actually play some sort of a role in terms of either contributing to maintenance of symptoms or causation, who knows. So I think this is where people are beginning to think about, the precision medicine approaches might actually help us to identify which subgroup of people might respond to adding some of those anti-inflammatory agents. So I think overall, just going back to the story that Daniel presented, in that particular study, we don't know why there was a reduced incidence of depression in people that received monoclonal antibodies. It could be an end result of many, many things. Maybe they have direct effect on some pathways in the brain that we don't yet understand, or maybe they target inflammation, maybe they target oxidative stress, who knows.
Just a very brief follow-up comment, which perhaps is kind of interesting. There's a difference between what the drug does once the disease has started. So anti-inflammatories may not have a treatment response in depression, but your study says they prevent its onset, which is a completely different question. And the question is, completely different hypothesis to test, let's put it like that. But if it's truly preventive but not therapeutic, that is a major thing to kind of dig into a little bit better, because you can see it as a high risk kind of, if you have extremely high risk populations, giving it as preventive intervention rather than as treatment.
And that could be tested with this same data set, right? Just swapping the...
Just to kind of follow on this discussion of your findings, Daniel, maybe it doesn't matter what the underlying disorder is if you're targeting the monoclonal to inflammatory pathway that's relevant for that disorder, and that, as you said, inflammation is sort of an underlying theme of some depression, at least. And so you may be just preventing it more, effectively by using that kind of targeted approach in that disorder, as opposed to like why a lot of these people get really heavy duty cyclophosphamide or talks about other things that or prednisone that lower inflammation, but I guess you didn't find that was helpful. So maybe it is that whatever pathway got upregulated to create that disorder somehow it enhanced their vulnerability for depression, so it was preventive. Like I think Sophia said, wasn't sure I heard everything, but
I mean, the inflammation thing is very tempting, right? And like, because as I say, people have been pursuing this for some time. But there's actually a study that Michael Burke, one of my friends from Australia, did, where he looked at the incidence of depression in people, older adults that were prescribed aspirin. And remember that we all used to believe that aspirin is a panacea for many, many things. So there was a massive study, thousands of people who were randomized to receive either aspirin or placebo. So just going with this inflammation hypothesis for depression, he predicted that those that were randomized to aspirin will have lower incidence of new onset depression compared with those that got placebo. And guess what? The finding was exactly the opposite. So who knows?
So just a clarification, Daniel, I didn't realize that. So the other arm gets small molecule treatments.
It's non-biological.
Non-biological, but they're also treated. Okay, I see.
Great. So I just want to thank you. I say thank you to everybody that presented this morning. So maybe we can give a round of applause.
So I'm Tim Murphy, professor in the department, and it's a pleasure to host the second round of lightning talks. And before we start with the talks, I'd like to remind people that we still have poster voting open. So if you go to the Slido link, there should be a poll for posters up, and vote for your favorite poster. So let's see, our first talk is going to be by Yasna Rafi. And Yasna is an undergraduate student in the NINET lab under supervision by Fidel Vila Rodriguez. And she's going to tell us about how TMS changes global connectivity.
Hi everyone, thanks for being here. My name is Yasna, and today I'm going to be talking about how transcranial magnetic stimulation induces acute changes in global functional connectivity. So TMS is an effective treatment for major depressive disorder, and fMRI studies have shown that instead of just affecting the treatment side, it impacts larger scale brain network dynamics. So one of the ways we can study these changes is by looking at global coupling. And we can find global coupling by finding the temporal correlation of the bolt signal of each of the vertices, and then taking the mean average for each vertex. And then we repeat that for all of the vertices across the surface. And then we can find this metric called the global coupling index. So that is the average of all those averages, which is a single summary that reflects the overall strength of coupling across the brain. And it is used to quantify overall coupling. We can also look at the topography. So looking at the bottom of the screen, which is a spatial distribution showing how coupling strength varies across the vertices. So instead of one value, we taking the average of all those values, we map them across the surface. And this shows us where coupling is stronger or weaker. So for this study, we were looking at data from our TMS fMRI trial from a few years ago. In this study, the participants had an acute depressive episode and had failed one or more antidepressants and had no significant psychiatric comorbidities. For data acquisition, the participants received a resting state fMRI scan, which was followed by a concurrent TMS fMRI scan. And the protocol for that was a 1 Hertz pulse delivery to the right DOPFC at 100% resting motor threshold. And then that was followed by another resting state fMRI scan. The entire data set consisted of 51 participants, and then after applying the exclusion criteria of more than 0.3 millimeters frame-wise displacement on any of the 3 scans, the final count came down to 34. And then the global coupling computations were done, and we were interested in looking at the difference between each of the resting states and TMS. So here are the results. So one-way repeated measure ANOVA showed that the difference between the 3 scans was significant. And then the pairwise comparison showed us that the difference between resting state 1 and TMS and then resting state 2 and TMS were significant, and there was a statistically significant difference between the 2 resting scans. And then also looking at the topography, we can see how during the TMS scan, the brain is more inhibited, or global coupling is way lower. And even though the difference between resting state 1 and 2 was not statistically significant, we can still see a pretty clear difference, where in the resting state 2, there are certain areas seem to be less inhibited, especially in the frontal areas. So some of the limitations of this study were the small sample size and the absence of a follow-up scan, so we can't really conclude that these changes persist over time. We can only see that it happened during the treatment. So for our next steps, we'll be looking at other studies that do have a follow-up scan to see if these changes stay after the patients receive treatment, and the effect of the different treatment protocols on global coupling, and also to see if global coupling can be used as a biomarker or a predictor for treatment outcome. Thank you.
Well, thank you, Yasa. And we'll have an opportunity at the end to ask all speakers for questions. The next talk is by Aksaj Sechdeva. And Aksaj is a co-op student from the computer science department, and he's working with myself and then also Joe Tam, and he's going to be talking about generating synthetic patients.
Hi, everyone. So my presentation is about creating and evaluating cognitive models and evaluating them for realistic synthetic patient simulation. So as many of you know, AI runs on data, and lack of realistic conversational data is a major setback for psychiatry researchers and developers looking to build LLM-based tools. Our research provides a substitute for this lack of data by creating realistic patient profiles as well as therapy conversations that can be used. To do this, we create a cognitive model, which is essentially a framework that dictates how a patient responds to, how they react, how they think about particular situations. And we combine this with detailed background and history fields, as well as a multi-agent patient response system. So an example of 2 back and forth turns between the synthetic patient is this, and the phrases highlighted in red show the capabilities of the cognitive model in exhibiting these reactions and emotions. An example of this is the patient saying that they are a fraud, which is an example of the core belief, which is a central part of the cognitive model, and the patient's responses are going to be based around that. So now that we have these transcripts created, how do we prove that they are a substitute to real data? To do this, we generated 792 transcripts across 25 to 55 turns in the 2 most common disorders, depression and anxiety. We ran them through an 11-dimension LLM as a judge evaluation criteria that was tasked with evaluating the quality of each transcript independently, and we ran them 3 times over each transcript. Some of the things that the evaluation criteria looked for are in the word map in the top right. We also noticed that the 3 runs were really consistent with each other with a 99% fly-stop agreement score. The median heat map is a table or a summary of results for the scores, and we noticed that our transcripts were scored really similarly to the Carl Rogers transcripts, which are real anonymized session transcripts all the way back from the 70s, which kind of speaks about the lack of real data in psychiatry now. We also noticed that our transcripts do not score similarly to some synthetic diagnostic transcripts, as well as some non-psychiatry NPR radio transcripts, which serve as a negative control test. To prove that these differences are statistically significant, we ran a Madden-Wheaton-New test, as well as a top-2 proportion comparison, and we noticed that our transcripts were similar to Carl Rogers, better in some dimensions, worse in some, and they were significantly better than the psychodiagnosis as well as the NPR transcripts. To quantify the impact of the cognitive model in these transcripts, we fit a Bayesian sampling-based regression model, and we noticed that in 10 out of the 11 dimensions, the cognitive model transcripts had a 74% likelihood of scoring in a higher category than the transcripts generated without cognitive modeling. So let's move on to the applications of this research. So we identified two main applications of our research, the first being data generation for other LLM-based tools. Our transcripts as well as the patient simulators can be used to evaluate the accuracy of these LLM-based tools. It can also be used to generate lots of data for other AI therapy chatbots, which is a popular area of research right now. An example of this is us running our transcripts through another project, which assesses the severity of depression from clinical interviews. And we noticed that our transcripts scored mostly in the moderately severe to the severe category compared to other data sources that we also ran through the same project. The second application that we do identify is obviously medical training. This can be used as a patient simulator for trainees looking to practice therapy in a risk-free environment and try different pathways, try different techniques. We can adjust the difficulty to match the training goals. And the graph here shows, or the diagram here shows some of the fields that make up the patient profile that can be changed as per the training goals. And the second is a snippet from our patient simulator creation menu, which shows how you can select different disorders to talk with a variety of different patients. And yeah, that's it for my presentation. Thank you.
Thank you, Akshay. Our next speaker is Brianna Leskovsky. And Brianna is going to talk about mindfulness for partners in postpartum depression and anxiety, mental health outcomes, and qualitative feedback on interventions. And she's working with Evelyn Stewart and Deirdre Ryan.
Thank you, Dr. Murphy, for the introduction. As just stated, my name is Brianna Laskowski, and I'll be discussing some of the work done with the reproductive mental health program at BC Women's involving postpartum depression and anxiety and our mindfulness-based intervention. For the study, we focused on partners of people diagnosed with postpartum depression and anxiety and mental health outcomes. So some background, postpartum depression and anxiety is incredibly prevalent in our society, and we see that it affects around 20% of families. And furthermore, we see that relationship conflicts and relationship dissatisfaction are both major predictors for postpartum depression and anxiety. And in beginning to address this issue, the majority of the focus has been on the birth parent at this point, and a non-pharmacological treatment option is mindfulness-based interventions. And we see that those are effective in treating postpartum depression and anxiety in the birthing parent. However, we also see that in partners of those diagnosed, they do have an increased risk of experiencing depression and anxiety symptoms. So much of the focus only is centered around the person diagnosed with postpartum depression and anxiety, and is only giving interventions to one half of the familial unit. However, we see potential in offering interventions to both partners at this time. So a little bit of background in MBIs, they teach a variety of skills, including emotional regulation and awareness. Thus, teaching these skills to both parents rather than just the birthing parent may help in reducing distress in the partner and therefore reducing symptoms of anxiety and depression in both parents. So in order to study this, we looked at the partners to see if this was effective first. And Our research objective was to investigate the effects of mindfulness-based interventions for partners and families diagnosed with postpartum depression and anxiety on mental health outcomes and relationship satisfaction. So in order to do this, we gave participants an 8-week mindfulness-based stress reduction program. And at week 1, they filled out a questionnaire and were given self-report measures for depressive symptoms using the PQH-9, anxiety symptoms using the G87, and relationship satisfaction on a 5-point Likert scale. We then did a paired sample t-test analysis after we got to the week 8 self-report results. So first, I'm going to show the negative mental health outcomes. So we see on the top, we have our depression score, and on the bottom, our anxiety symptom scores. For both, we see a small but significant reduction in these symptoms with a mean difference of 2.35 for depression symptoms and 2.4 for anxiety. And then on relationship satisfaction, we see, again, a small but significant increase in satisfaction with a mean difference of 0.35. So our takeaway from these preliminary results is that mindfulness-based interventions, and in this case, mindfulness-based stress reductions for partners, can help reduce distress and strengthen the relationship during the postpartum period. So these findings indicate that there is potential in focusing effort on the partner of the parent diagnosed with postpartum depression and anxiety, and hope that we can integrate this care into family units rather than just placing the burden of treatment on one parent alone. Thank you so much.
Thank you, Brianna. Our next speaker is Orly Hellerstein, and Orly is working with Ray Lamb and then also JJ Nunez, and is using machine learning methods to evaluate outcomes after escitalopram treatment for major depressive order.
So thank you, Tim. My name is Orly Hellerstein. I'm a research coordinator with Dr. Raymond Lamb. Before I launch into the projects that me and JJ have been working on, how many folks are familiar with machine learning in any capacity? Some, sort of? Great. All right, so we are going to be talking today about using clinical data with machine learning to predict functioning outcomes after escitalopram or Lexapro treatment for major depressive disorder patients. So a little bit of background on this. Major depressive disorder impairs functioning. That means that when you have major depressive disorder, doing things in your day is a lot harder. In fact, major depressive disorder is considered a leading cause of disability globally. And it also impairs functioning in sort of specific areas of your life where you might need a little extra energy to get things done. That's a real problem because patients value functioning a lot. Getting things done is actually considered more important to a lot of patients than feeling better or symptom improvement. Unfortunately, a lot of major depressive disorder patients remain functionally impaired despite treatment, even if they achieve symptom remission. So even if they start feeling better, their sort of ability to get things done, their ability to be out in the world doesn't necessarily improve. So we know from previous work that machine learning models can reliably predict symptom response to treatment, so changes in levels of symptom severity as a result of treatment. But we don't really know what happens to functioning. Can machine learning models predict changes in functioning? So that's what we set out to figure out with this project. I'm not going to get a ton into our demographics or our eligibility criteria. The basics that you should know is that we had 174 participants from a larger data set who completed measures of functioning on the Sheehan Disability Scale at baseline in week 2, and then also at week 8 after 8 weeks of escitalopram therapy. And we used machine learning models to predict both functional response and functional remission. The difference there is just how big was the change in their ability to function. If it was functional response, that means we saw some amount of change. If it was functional remission, that means we saw a lot more change in their ability to function. We used 5 machine learning models, a mix of decision tree approaches and linear and regression model approaches to predict total score on the Sheehan Disability Scale. We use that for global functioning, and also some domains of functioning, specifically how are folks doing at work and school, how are folks doing in their social lives, and also in their home lives. I'm not going to touch on our secondary objective too much today, just because we're still working on the results there, but we are also curious which variables are most relevant for the prediction of functioning outcomes. So here's what we found. In general, model performance is assessed using an area under curve, or an AUC score, above 0.7. This is a number set by previous researchers. These models are specifically trained on a subset of clinical variables from our larger data set known as Tier 1 variables. These are just variables that we think are really clinically important. Overall, our predictive performance is modest, and mixed effect analyses indicated that functional response, generally easier to predict than functional remission. Not super surprising, it's sort of a lower bar. In our results, we found that the support vector machine, the random forests machine learning model, and the gradient boosted decision tree model were all able to predict functional impairment response using the Tier 1 variables, but only the gradient boosted decision tree met that 0.7 AUC cutoff for functional remission. What's especially interesting about these models, being able to predict some kind of change in functioning, is that they're all decision tree-based approaches, which is sort of a branching logic approach, and that may have significance for future research. We also looked at how we were able to predict global functioning versus specific domains of functioning, what was easiest. And what we found is that both we were better able to predict domain response and remission than global response and remission, but more specifically, the home domain and the social domain were easier to predict than global response, and were also easier to predict than, or more successful in prediction than our work domain. So a little bit harder to predict the work domain, a little less reliable when working with our models. That's a lot of words. If you only walk away with one thing today, it's that ML models may be really useful tools for predicting antidepressant treatment effectiveness. That can vary depending on the model, although the 0.7 cutoff, AUC cutoff, is not a clinical cutoff. A lot of our other models are pretty close to this number, so there might be something more to explore there. And we also want to think about how ML models, how specific we're getting in what we're asking it to predict. Thank you.
Thanks again, Orly. And our last speaker is Tom Sarowski. And Tom is working with Ray Lamb and then also Joe Tam, and is going to tell us about intravenous ketamine and experience at the Squamish General Hospital. So Tom.
Hi everyone, thanks Dr. Murphy for that introduction. So yeah, as you mentioned, my name is Dr. Tom Sarowski, and I'm one of the first-year psychiatry residents here at UBC. Today, I'll be presenting clinical outcomes from the ketamine intervention program at Squamish General Hospital. My co-authors and I evaluated the efficacy, safety, and some longitudinal outcomes of a protocolized outpatient intravenous ketamine intervention for treatment-resistant depression. Before we jump in, I'd like to thank my supervisors from Squamish General Hospital, Dr. Wynn and Dr. Leon Carlisle, as well as my UBC supervisors, Dr. Tam and Dr. Lamb. So to begin, our target population consisted of outpatients with treatment-resistant depression. To be included in the study and be referred, patients had to be 18 years of age or older and be currently experiencing a major depressive episode. For the study, resistance was defined as failing 2 or more adequate antidepressant trials alongside failing 1 adjunctive treatment for major depressive disorder, or for bipolar depression. Resistance was defined as failing 2 or more adequate trials of bipolar agents. The acute protocol consisted of intravenous racemic ketamine administered twice weekly for a total of 4 treatments. The dose was initiated at 0.5 milligrams per kilogram and with room to up titrate to 1 milligram per kilogram, depending on individual clinical response and tolerability. So this update includes data from 55 outpatients at Squamish General Hospital. The mean age was 45 years old and 47% of participants were female. The resistance in our cohort was quite profound. We found that a mean duration of the current depressive episode was 40 months. Additionally, the majority of the cohort had some comorbidity, with 71% having at least 1 psychiatric comorbidity, most commonly anxiety, ADHD, or trauma and stress-related disorders, with a further 33% having at least 1 medical comorbidity, primarily cardiovascular or neurological. This chart on the right shows lifetime interventional treatments for depression between the Squamish cohort and the UBC ketamine cohort. As you can see, the UBC cohort in the red bars had a significantly higher rate of ECT and TMS use compared to the Squamish cohort, with the Squamish cohort having only 13% ECT lifetime use and 4% TMS use, which may reflect differences in access to neuromodulation. So for our results. So we found the IV protocol showed results initially and 3 months after finishing treatment. So the graph on the top right shows patient health questionnaire or PHQ-9 scores at baseline, after treatments, and after completing a 4-treatment course. The blue bars represent the average PHQ-9 scores, and the red line represents the change in score from baseline. So as you can see, at the 1 week after treatment mark, we found an average 31% reduction in PHQ-9 scores. This subjective response was also corroborated by clinician metrics. The average clinical global impression scale was 2 out of 7, or much improved at the 1 week post-treatment mark as well. Tracking these patients longitudinally out to 3 months post-treatment, which is that rightmost bar, showed sustained clinical stability with average PHQ-9 scores maintaining at about 24% from baseline. Now looking at the bottom right graph, this is the European Quality of Life 5-dimension score, the EQ5D scores. Again, we found an initial 23% increase in self-reported quality of life after 1 week after treatment, and this sustained to about 9% after completing the treatment course. Additionally, a subset of patients who had a positive response to the initial treatment were offered maintenance treatments, receiving ketamine every 4 to 12 weeks, and these individuals showed further improvements in the EQ5D scores as well. And then finally, in terms of safety, across 322 total administrations, the intervention was exceptionally well tolerated. We recorded no major adverse events beyond the expected transient dissociative effects from the ketamine itself. And we had 1 episode of hypertensive urgency, which resolved with captopril administration. So, in conclusion, outpatient ketamine has delivered a clinically meaningful, safe, and sustained intervention for a highly treatment-resistant population. Thank you very much.
So I'd like to invite all the speakers of the second round to come up, and questions from the room.
Yes, hello. So there's a question online for Brianna, right? So the question is, how clinically relevant were the changes in the scales?
So clinically relevant, we do see that there are significant reductions in symptomatic scores, but also the partners of the patients diagnosed with postpartum depression and anxiety aren't a clinical population, though we do see that there is some association with increased symptoms in previous studies. It's not necessarily like the clinical population that we're looking at. We're more so looking at like a first step to then help decrease, or I guess increase, well-being in the familial unit, and just using partners to help support that rather than just placing burden on the birthing parent.
Firstly, a clarification. I'm sorry if I wasn't paying sufficient attention. So we have 2 people. Yes. And the result that you presented is the non-birth partner's results.
Yeah.
Correct?
So I guess to be like a little more clear, the sample was mainly cisgendered heterosexual men, so like the fathers in this case.
Yeah, but just the fathers.
Yes.
But the intervention was given to the mothers and the fathers as well, or was it a study that only the fathers received an intervention and the mothers didn't?
Yes, so this is part of a larger study. So the fathers or the partners are having a mindfulness-based stress reduction 8-week intervention, and the moms or the birthing parents are having an 8-week mindfulness-based cognitive therapy intervention. So
both with interventions, but separate things.
Yes, but they're having all of the same self-report responses and all the scales, so they're both being assigned the same surveys.
Do you know? And I was interesting about the the fact that the fathers rated and their relationship with their mother improved, did the mother also think the same about her relationship with the father?
Yes. At this moment, I can't remember exactly what the numbers are, but I do recall seeing like an increase in relationship satisfaction. We're still working on like qualitative interviews for this study, but some of the participants that have been taking place are talking a lot about how these skills that they're learning are helping open up communication between the two of them and giving better ways to manage conflict that leads to more satisfied relationship.
And I think this is a very fascinating topic because there's actually quite a strong literature now that upwards of 1 out of 7 fathers develop postpartum depression. Mm-hmm. And I was wondering, when you showed the improvement, but did you also do a baseline assessment to see whether actually the fathers had postpartum?
Yes. So they were given the PQH-9 and the GAD-7 scores. None of the like fathers or partners in our sample had like a high enough score to be like diagnosed or like clinically, but I assume if this continues and the sample size increases, we might end up seeing that.
Okay, in the back. I had a question for Tom. I think you'd mentioned that you'd looked at both like major depressive disorder and bipolar depression. Have you seen differences between the two?
Thanks for your question. I believe the cohort was about 75% unipolar depression, 25% bipolar, but we haven't done a separate group comparison yet. Yeah.
It's another question for Tom. Might as well keep you there. I was just curious if you had collected any specific data regarding suicidal ideation and if you saw any changes there.
So the question was if we collected data on suicidal ideation. Initially, at least at the Squamish cohort, I don't believe we had enough completed data to finalize anything, like publish any good numbers from that. So
while you're up there, Tom, very nice presentation. So the Squamish cohort had the intravenous ketamine, while the UBC cohort uses the subcutaneous. There's kind of a more propensity for adverse effects for IV, just from the IV, right? Like bruising and pain and blown veins, etc. Did you get any of that, those kinds of adverse events from your chart review?
No, it's primarily the kind of dissociative effects that were most noted, like in the charts and like the self-report measures. But yeah, those kind of minor adverse effects were not calculated for every single person. So yeah, it is a lot more annoying to get the IV than subcutaneous for sure.
So Tom, another question for you. So again, we'll just double check with Joe to make sure that I remembered correctly about what data we gather for patients that go through the ketamine program. And our recollection is that all patients will have had PHQ-9 and MADRS completed. Yeah. So I think to Trisha's question about ketamine, obviously the reports of it having anti-suicidal effect, and there is an item on MADRS that captures a suicidal ideation. So you may want to have a look at that and see if there is a change and how significant the change was for people that got the ketamine.
Yeah, it'd be interesting. To compare to the Squamish and the UBC cohort for that as well. Yeah.
Hey, there's a question for Yasba regarding the RTMS protocol. I see that you're looking at that global connectivity score, and it looks like the procedure is you get the fMRI for 5 minutes resting, then you do, in the midst of the TMS, another capture of the fMRI result, and then you turn off the TMS machine, and then you do another 5 minutes capture, right? Basically, yes. Yep. Right. And the only data you found that was significant was that in the middle second step, where you turn on the RTMS machine at 1 hertz, you're noticing the global connectivity change, right?
Yes. Yep.
And after you turn it off, then between the two resting states, when you turn off the machine, there's basically no change.
Yes, if we look at the mean values, they're pretty much the same.
And literally, this is like on, off every 5 minutes?
So for the second part, so it's a concurrent TMS fMRI, so they're getting TMS while they're getting the fMRI. It's just like the timings planned, so the pulse delivery doesn't interfere with the
Right.
fMRI sequence.
Yeah, so a couple of questions. So first of all, why choose the low frequency right RTMS rather than, say, very typical higher frequency 10 hertz left TMS? I'm just curious because, is that just a methodological thing because a high frequency RTMS would cause too much disturbance to the actual data capture? And secondly, it's a little disappointing, right, that even after the RTMS, basically you can show that the RTMS has affected the neuronal system such that there's some functional connectivity changes, but immediately after you don't even see any change, even though it seems like it's literally at most a few minutes between on and off. Hey?
Yeah, so to answer your first question, I'm honestly not sure. I don't know if anyone else from the lab knows why we did RTMS instead of ITBS for that trial. It was before I joined the lab, so I'm not sure. But for the second part, yes, well, for this study, we don't really have a follow-up scan, so we can't really conclude that it is just for the change persists. But I have started looking at our other data sets from our other trials, and we have found that global coupling actually increases significantly after the patients are done receiving the treatments. So
you're finding changes after, say, 20 treatments across about a month.
Yes.
But unfortunately, in this very short-term trial, you're not able to find the continuation of a global connectivity change, even though literally just turn it off, nothing kind of lingers even for a few minutes afterwards.
Yeah.
Interesting. Okay. Yeah, thank you.
Yeah, maybe the changes accumulating after each treatment would be my guess.
Oh, and just one quick question. So in terms of the 1 hertz treatment then in that middle phase, that means over 5 minutes, that's 300 pulses. So there's no change before and after over over all these hundreds of pulses.
Yeah, so we take the average value for those 5 minutes. So we're just looking at one index. So I'm not really sure if it's like from the beginning or end of the 5 minutes, how much it's changed.
I guess I could ask a couple questions. So for Orly, let's see. So you kind of benchmark these different models. Does the performance of the models, is it as you would expect for predicting other variables, or is there something, I don't know, special about these like depression, these types of scores?
Thank you, Tim. I have only read research relating to depression and these kinds of predictions and predicting scores in my work with JJ. I'm certainly no machine learning expert. However, we do see that in the research on symptom severity and on symptom change that yes, these models are able to predict sort of what's happening with symptoms. Do I think that there's something unique about depression? Probably not, but that would be my own speculation. I imagine if you did this kind of trial with bipolar disorder or with maybe like an anxiety or psychotic disorder, you would see something. But I'm hedging my bets there because I am certainly not an expert in machine learning. Does that answer the question?
I guess just wondering about other prediction of some ordinal variable or something.
JJ, do you have thoughts on this? I certainly do not.
Yeah, it's actually pretty similar in terms of depression severity versus functioning. It's quite similar.
Yes.
Actually slightly better for functioning so far than depression severity.
But if your question is like, how good would we be at predicting, I don't know, is the sky blue tomorrow? That's like a very base example, but is that the question?
Well, I guess we have other, like these models are used for a lot of things.
Absolutely.
And they have, I don't know, benchmark performance, or it's sort of known that some are better than others. And does a prediction of depression scores fall along usual, I don't know, norms for model performance?
So my understanding is that there are, and again, JJ, please interrupt me if I'm speaking completely out of the blue, is that machine learning models, these 5 were specifically selected for the prediction of sort of depression, originally symptom severity, and therefore we also use them for, go.
Well, so I think it depends what you're trying to predict, of course, right? But in mental health, it's hard because inherently psychiatry is hard. Mental illnesses are hard. They're extremely diverse, and we could all talk about that a lot. A cool thing is one of my projects was predicting cancer patient survival, and then the AUC like shoots up way past 90. Like you could do it really effectively because whether somebody survives cancer is a very medical, very based on all these factors that we kind of know about. Whereas psychiatry is just complex and hard, and that's why we're all here.
Yeah.
So.
And the selection of models is often one of the coolest and also hardest parts of doing this kind of work, of like which machine learning models are you using. JJ was very intentional in the 5 that he chose, and also was echoing previous research in a very similar field.
So, a question for Orly again. I'm curious about what you actually were giving to the model as input. How many variables were in total? And if you could give examples of this, in case there's like hundreds of features that you're actually using to train.
Yeah, with pleasure. What was your name one more time? Sorry.
My name is Federico. I work with Tim Murphy.
Nice to meet you. So in terms of this particular project, I only spoke to tier 1 variables, which is obviously not a descriptive title. This included things like biomarkers, demographics, some clinical scales like the MADRS and functioning, Shan Disability Scale. We saw mostly that those self-report or clinician-rated surveys were showing up. We also took, I think, a total of 296 variables in sort of our larger data set, which we're still working through.
How many people, how many patients?
We worked with 178 in this sort of subset, and that's limited by like who finished all of it. Yeah, at the 8-week mark.
Actually, a question for you, Yasna. You mentioned a little bit that that you saw long-term effects, right? Have you imaged people over time to see what actually the time course is that you're inducing? And with that, you see any contextual effects that could help you explain what the intervention is actually doing?
Yeah, so most of our studies have had a baseline scan and a follow-up scan. So it's just been before the first treatment and then after the last treatment, or like 2 weeks after the last treatment. So that is the effect that we're measuring, or the change that we can see in these trials. We started looking at treatment outcomes, so how patients have responded to treatment, how their cognitive performance has changed. So we're trying to see if the change in global coupling can at all explain that, because we have responders and non-responders in these trials. So really nice to have this metric that we gather at baseline that can help us predict how the patient's gonna respond to treatment.
For Akshay, you did a really nice job in comparing the different ratings that you applied to the simulated patient. Have you also started looking at the acceptability of the simulated patient by mental health providers?
So right now, all of our research has been relating chatbots, and we have not worked with a lot of experts in psychiatry, but that's going to be something that we are planning on doing to extend our research, as well as extending with a lot more disorders. Right now, only the LLMs have compared these transcripts and how good they are from a realism point of view, but to get experts in psychiatry or licensed clinicians to do that and to interact with the patient a lot and then score them would be something that we are aiming to do as extending our research, yes. And that would help us obviously get into the training part of it as well.
Out of curiosity, there are many commercial packages that are already available with simulated patients. How does your project fit in that sort of landscape?
So a lot of the projects online right now are focused around the interviewer and therapy chatbots, and not a lot of people have looked at the patient side of it, which I think is a pretty important side of it as well, because obviously you can't really train LLM interviewers and chatbots and try them with real patients. So having them to work with synthetic patients is going to be that. I'm not sure I understand your question 100%.
There are packages where people have used real patient data to create synthetic avatars of patients. Yeah, so this is for training purposes for clinicians, and I was just wondering whether parts of your architecture or parts of your training is similar with what has been done in this landscape before. That's all.
So in terms of real patient data, we also have used a lot of demographic data as well as real anonymized profiles to base our patient profiles on that as well. So I think it is really similar to that. And I mean, in detail, if I were to go in detail, it would mostly be around just real situations that these patients faced, as well as their cognitive models, which were designed by licensed experts. And as well as demographic data has been sampled from the British Columbia mental health statistics. Yep.
Just one last question for Orly. Sorry. I just had so in the Kanbine data set, which is what you were using, they had obviously looked at predicting clinical response, so like a 50% reduction in symptoms. You're looking at something different, like functional changes. But I'm just wondering, was there a dissociation between people who fit criteria for clinical response and functional response, or is it essentially the same 50% of people that we see who improved clinically, who had a 50% reduction, who also were functional responders?
Yeah. In this particular set of analyses, we didn't do comparison. We didn't look at how people were symptoms improving and how they were functionally improving at the same time. That was done in the paper that I mentioned in sort of the background. I would be pretty surprised if there wasn't some correlation, but I don't know how strong that correlation is. So I can look into it and get back to you.
I guess I've got a question for Tom. So one thing that struck me was the difference in the incidence of ECT and TMS at the Squamish Hospital. So I'm just wondering about, I guess, experiences of kind of putting together data from regional hospitals and whether you might, I don't know, underrepresent some procedures or...
Yeah, that's a good question. I think that'd be a better question for probably the clinical individuals who are actually recruiting the patients, meeting them, because, yeah, I personally, as a first-year psychiatry resident, I'm not prescribing these treatments at this point or having patients come in personally with those. But, yeah, I think that was just one thing that came out in just comparing the UBC and the Squamish cohorts was we wanted to see, is this kind of like treatment resistance, like could use of neuromodulation be a proxy for how resistant their treatment or their depression is? But like I mentioned, like lack of access to treatment could be one reason why it's different, or these cohorts could be truly different too. It's not really possible to say without kind of parsing it more than that. But yeah.
Hey Tim. Yeah, I just wanted to say, that's a great question, and that actually got to the heart of why we're doing it in Squamish. From a regional perspective, we have a cohort of patients out there with treatment-refractory depression, difficult to treat depression, where it's very hard for those folks, all along the Sea to Sky corridor to come down to, say, Lionsgate Hospital being the closest hospital, or down to VGH, UBC for ECT. So that's why we actually started that program up there for ketamine, so that those treatment-refractory folks can have a place to go. So it's actually good that they captured that difference between an urban and a rural center, because if the ketamine works quite well for the refractory depression patients, then that could be the first port of call, in that hospital, instead of having to come down to the city and get ECT and such. And ECT, TMS can be, a further down the road kind of protocols that we could use for those patients.
Okay, well, I'd like to thank everyone, all the speakers. These were amazing talks, both sessions, and thanks again.
I'm Joseph Tam. I'm one of the clinical professors here at UBC. It is my distinct pleasure to introduce our two faculty speakers this afternoon. The first speaker, and by the way, thank you, Dr. Paulus, for getting us started on the discussions around AI and models such as this. And as you can see, that theme is is present this year, a lot more than in previous years when it comes to research. So perhaps this is something we'll see down the road continuing as well. AI is certainly here to stay, regardless of whatever happens to the financial markets, I think. Now, the first speaker this afternoon, faculty lecture, is John Jose Nunez. John Jose is a psychiatrist and researcher whose work combines psychiatry and computer science, and is an assistant professor partner in the UBC Department of Psychiatry. He holds an MD and MSc in computer science from UBC and is a fellow of the Royal College of Physicians and Surgeons of Canada, Psychiatry. A graduate of the department's residency program research track, he was a two-time IMH Marshall Fellow, 2022 to 23, and then 23 to 24. He's supported by the UBC Institute of Mental Health and the BC Cancer Foundation. Following his fellowship, he was appointed as a clinical instructor in the department in 2024, contributing to both research and teaching. His research explores the use of computational methods, including AI, machine learning, and natural language processing, to improve outcomes for people living with mood disorders and patients managing both cancer and mental illness. So the floor is yours, JJ.
Okay, first I'm going to start by absolutely thanking you all for still being here. Okay, so disclosures, just some money from Amazon, Pfizer back in the day. But of course, I think more importantly is really the intellectual bias that I am an AI researcher, so I obviously do have a little bias towards this stuff. But I do really like to say that last line there, which is there's definitely no such thing as an AI expert. This field is moving so fast. So if you have like corrections or you like tell me, why are you doing that? You should do something else. Please do let me know. And then I also like to throw in this slide. I once had feedback on some talk I gave, which was along the lines of essentially, you know, Dr. Nunez seemed very excited when he was talking about AI, but I think it's going to end humanity, which is kind of a fair point, right? And so I do think like any big technology that's coming to society, just like the internet, there's going to be lots of pluses and lots of potential minuses. So, you know, I would be very happy to answer any questions about this, talk about environmental impacts, whatever else, but I'll be mostly focusing today on kind of some positives and potential applications within psychiatry. Okay, and also kind of define some common terms and whatnot today. But I also like to include this slide, which is just, you know, what do I see the point of using all this technology, right? And you know, first off, I really think I got into this field like over 10 years ago because I was seeing what the tech giants were doing. You know, they were using all this AI even back then to do stuff, especially like targeting ads. And so instead of using it for that, which I mean, sure, capitalism, whatever, could we actually use it to do stuff like helping our patients, right? And I really see and hope that AI, at the end of the day, is going to help empower patients to get better care, to make more informed decisions, to understand what's happening. I hope it's going to help clinicians give more evidence-based care and more targeted and more effective care, especially in psychiatry. But I also really hope that it actually puts the doctor-patient relationship back to the forefront. Help get rid of all the paperwork that we're doing and having to look through this and look through this and really get it back to relationships, because I think that's such an important part of medicine and you know, society in general. Okay, so I'm going to start by talking about what actually is AI. I do apologize. I know some of you in the audience have probably seen this slide about 400 different times, but you know, there's so much talk of what actually is AI. I give this joke, but nobody usually laughs. You don't have to today, no pressure. But that AI is just anything that somebody's trying to sell you these days. So let's actually talk about what the definition is, right? And when you generally are using a computer or cell phone or whatever, anything digital, most of the interaction is with explicit instructions. A programmer, or I guess now a coding agent, but whatever, has written something like if press equals true and cursor position equals whatever, then it'll open your favorite app, right? And this works great for most of interactions with computers because it's very limited kind of situation of what could happen. But once we want to interact with the real world, it gets a lot more difficult. And so here's my trusted example. You'll see some digits there on the right. This is one of the first examples of AI really being used in society, which goes back to the late 1970s, 1980s, right? AI as a field goes back to like World War II or even earlier than that. But this was one of the first real kind of applications that we're seeing in the real world. The Postal Service wanted to recognize zip codes, 5 digits, so that the mail could be sorted. Very understandable. But you can imagine if you try to tell a computer, okay, what's a 0, right? What does a 0 look like when hand-drawn? You could tell it that it's a circle, but then, not a lot of people don't connect the zeros. Or an 8 is 2 circles, but again, it's not going to work. So instead, we need a way for the computers to actually teach themselves how to accomplish these tasks and deal with all these kind of messy situations that we could have in the world. And that's really what artificial intelligence is all about. You might be wondering, okay, people talk about AI, but I just have this chatbot. When are we going to get to like the robots in Star Wars or whatever else? And really what those are is what we call artificial general intelligence. The big difference being that instead of just the system being able to do one task at a time, it could do many, many tasks together and so on. And I think we're starting to move towards that in what's called agentic AI, which I'll also talk about a little bit later, which is really AI that could work a bit more with the environment and do different tasks and kind of hook things up together. Okay. You may have also heard about the term machine learning. Machine learning is really the kind of most common way that we're teaching AI how to accomplish tasks. And the analogy I like to use here is that it's actually very similar to medical school. When I showed up, in third year, you show up to the hospital for the first time, you see a patient, you have no clue what's going on, or at least I didn't because I've never been that good of a student. And then your preceptor will be like, oh, that person has their right lower quadrant pain, that's an appendicitis, or whatever, so on and so forth. And you get this training data, it's labeled by the supervisor, and after you do it 1, 2, 300,000, you eventually build this understanding. It works very similarly for our AI systems doing machine learning. We give the training data, give the labels. We then use a little bit of calculus, and it teaches itself how to do these tasks. And then you may have also heard of the term natural language processing, also NLP. I also find this a really funny one, even though I've defined this again many times, but we use the word natural because if you tell a programmer language, they immediately think like Python or JavaScript instead of thinking like English or French. So natural language just means human language, and the idea of NLP is systems that could work with human language, which is really cool to think about, because at the end of the day, you have to convert words, which have such nuanced and interesting meanings, into ones and zeros, right? That's how computers work, and so there's lots of different ways to do that, and kind of how you design the brain, which gets quite fun. And of course, if you've now used any of our conversational agent chatbots like ChatGPT or whatever else, that's a great example of NLP. Okay. And then before I actually get into AI, I also just like to bring up this slide, which is don't forget about data science, right? There are so many important things we need to be doing in the healthcare system that don't need complex AI algorithms or whatever else, but just need like simple statistics and collecting our data, right? Knowing like, oh, what's the distribution of illnesses that we're seeing? Maybe that's sufficient for us to make some really big, impactful decisions in the healthcare system. I'm seeing more and more that everybody just wants to talk about AI, and I get it. It's fun, it's exciting, but there still is a lot of cool data science stuff that we should be thinking about as well. All right, so I like to categorize AI into 3 broad examples. Probably the most correct way is to call it predictive and generative, but I like to add extractive or summative because it's a kind of a different kettle of fish that is really important to deal with healthcare data, which often there's tons and tons and tons of, and we want to try to pick out the needle in the haystack and actually understand what's happening. So I'll talk about that, and then I'll talk about predictive and generative applications of artificial intelligence, which are the 2 kind of main categories. Okay. So again, the idea in extractive artificial intelligence is that we have some big data set, and we want to collect some useful stuff from it. Right? And I sometimes call this putting the medical student summer project out of business because historically we'll have the chart review and you got to go over and over and over again. But AI actually allows us to be able to do stuff like that quite efficiently. So here's one example that we did quite recently. We have the AMA Ask Me Anything Reddit posts. So this is a annual activity that we do with Erin, I don't know if I saw her yet today. I don't know, she's somewhere. Where all these patients, hundreds of patients with bipolar disorder, could log on to Reddit and then ask questions they'd be wondering about to experts, which includes psychiatrists and peers and researchers and so on. And so we'd be doing this for I think 5 or 6 years, and we thought, okay, what are people actually asking about, right? And by that point, there were thousands and thousands and thousands of these questions. So you could imagine this would be very hard for a human, or at least tedious for a human to do, to go through them all and, okay, this topic and this topic. So you could use some artificial intelligence techniques to actually do this for us. And therefore, we could see that we had these different, you can see 11 different topics there on the right of kind of the top topics of the questions that folks were asking about. And then we followed up to this work by doing I think it's an interesting investigation of, well, do the topics that patients ask about line up with the things that researchers are actually studying, right? And to be fair, it's not, people weren't asking questions because they wanted researchers to research those topics, but we still thought it would be an interesting idea. So we did a similar technique with PubMed abstracts, and then used some other computational techniques to compare how similar or different they were. And you can see that there actually is quite a bit of overlap, but also quite a bit of difference. A lot of patient questions are about misdiagnosis, and we know that bipolar disorder takes such a long time to get diagnosed, and yet there's actually not a lot of research looking to try to figure out how to improve that step. Okay, so predictive artificial intelligence. The idea here is that we're predicting something that happens in the future that we don't know about, or that we're classifying something right now that we also don't know about. And this is kind of an interesting one. I used to say that you need lots and lots of data to do predictive work, but now we have the foundational models that we could do stuff like transfer learning. So this is getting easier, but still, I like to say that you at least need a few hundred examples if you want to build predictive models. Preferably, though, you have thousands and millions and so on. So there's many examples one could go over about predictive artificial intelligence in psychiatry. We had a great plenary talk on one that we could potentially classify as that, or really just talk about our work predicting functional outcomes. We've also looked at stuff like predicting whether antidepressants will help quality of life. Other folks have looked at things like who will actually develop lithium toxicity if we give it to them, so on and so forth. And you could use all sorts of different data to make these predictions. Often the problem is actually getting enough getting enough participants, as opposed to the depth of the data when it comes to clinical machine learning. But you could use stuff like imaging results, biomarkers, omics, lab results, symptom scales, so on and so forth. Okay, so here's one of the papers that we did somewhat recently. So I work in both mood disorders and in cancer psychiatry. And a big problem in cancer psychiatry, if any of you have worked in kind of medical domains, is that we often get patients referred to us very, very late, right? The folks are already they're getting suicidal, they're so depressed, or they're so depressed they want to stop taking their chemotherapy, or they're getting so anxious they want to stop their chemotherapy or whatever else. And so we asked the question, well, could we try to predict this earlier? And then we could potentially, refer folks to see a counselor or even refer to see us, but just before their depression or anxiety or whatever else is getting super bad. So we wanted to use a data type that was actually available and already readily collected. So we looked at the initial oncology consultation document, the document the oncologist writes when they first see the patient, and then trained some NLP models to see if that could predict whether someone would be likely to see a psychiatrist or counselor within the next 12 months. And this actually works quite well, even though the data is very different. Right? This is a medical document. Most oncologists don't talk about mental health. Yet you can actually use it with an AUC kind of around 0.8, which is a bit higher than a lot of other these predictive tasks in psychiatry. Sorry. And then the really cool thing, cool once I did it. The reviewer who asked for this, it was right at the start of my summer. It literally took the entire summer, so I don't think I saw the sun for those months. But they asked for us to figure out, okay, so you got this model that seems to work pretty well, but how is the AI actually making these decisions, right? So we got to invent a cool new interpretation technique to actually look inside the brain of the AI and figure out, what sort of sentences were being used. And this is hard because this was about 40,000 patients of data. So again, you can't just get a human, manually look at it. And so we combined a couple different techniques, and here you can see the results. This shows the topics, the types of sentences that were commonly being used for these predictions. And you can see that the top one is just like a history of whether the person has a depression, sure. But that actually was by far not the majority of the sentences that were being used. And you can see kind of some interesting things. Breast cancer, as we know, is very correlated with psychosocial needs. If you we're having both chemo and radiation, that would bump up your chance of developing psychosocial needs. Peripheral edema, if you've done some CL psychiatry, you'd probably recognize that that is usually from steroids, and steroids, of course, can cause psychiatric needs or can also mean that somebody has CNS tumors, brain tumors, which also increase needs. So anyways, you could do some cool stuff and actually look at what the AI is predicting. Okay. And then, of course, we'll get to generative AI. And the idea with generative AI is that we're really putting in some like undescribed amount of data and then getting some undescribed amount of data back. It's not necessarily this, binary 1 or 0 that you're doing in your predictive AI. And of course, the big application for this in the last few years has been our conversational agents, right? And I think there's this interesting debate right now in the field about whether we have too much focus on conversational agents, on chatbots, right? There's so many cool things we can do with AI, so is this the only thing we should be focusing on? But at the same time, I would argue that we have never seen a technology be adopted as fast as chatbots. Like, it blows everything else in the water, the internet, cell phones, everything else. And that's probably because people like to interact with technology in a natural fashion, in a conversation. We're humans. We don't go up to somebody else and like move a mouse cursor around them. We talk to them, right? And so chatbots allow this, and I think that's why there's a lot of interest, and so there's a lot of cool stuff we can do. But of course, lots and lots and lots of potential risks, right? The inaccuracies, the hallucinations, and so on and so forth. But let's show a couple examples. And this was a recent paper that was just accepted, which is a generative AI application to help clinicians use the CANMAT bipolar guidelines. We know that one of the barriers to using guidelines is that they're long, they can be complex. I've had the experience where I was like, oh, I really want to know what the guideline says about this, in front of the patient, and I'm like searching, can't find it out. So can we get a chatbot to instead give a quick answer that's actually based on it? And we could use something called retrieval augmented generation, which means that instead of the chatbot using its knowledge from the entire internet, all the 4chan threads and everything else, it'll instead use the document that we give it. So in this case, the guidelines. And that worked quite well, but lots to still do to get these systems really accurate. Okay, and with that, I'm going to wrap up on agentic AI, because this is something that's pretty fun. And I really like the quote from Anthropic there at the bottom, that there's no real definition of artificial intelligence, of agentic AI, which is, I think is honestly probably true. But some examples or some ideas of when we're kind of moving into this agentic realm is that we're having these multiple steps that could interact with data. So I'll give a fun example. Well, I think it's a fun example for myself, which is I have a computer that can run some local LLMs quite effectively. So I've actually connected it to my bank account. So I could automatically generate like stuff for my accountant and like forecast and everything else, right? And so this ability for our LLMs to not just like give you a little answer, but actually connect to like other data sources is quite powerful and quite exciting. I think there's a lot of cool stuff that we're going to be able to do. But we could also use this agentic approach to have AIs talk with each other to do multiple steps. And so, oops, sorry. Okay, and so we're currently doing that now actually for both a new version of the bipolar chatbot and a version of the depression chatbot, where we have different AI steps to identify what sort of question this is, and was that question answered correctly. The AIs that kind of talk with each other and help build an actual better response, as opposed to just a standard RAG system where you're essentially just asking the RAG one question, hey, what's blah, 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 what's the best treatment for this situation, and then it gives you an answer back. The agentic system allows a bit more interesting and complex thought to hopefully make things better. So with that, this link will hopefully work in classic John Jose fashion. I forgot to actually make sure it was working today, but you're welcome to scan the QR code. If it doesn't work, you can follow up with me and I'll send you a link. But this is one for depression that we've been developing as of late. You're welcome to give it a shot. And otherwise, I will thank you very much for your time and choosing me over the Canada game. Very happy to answer any questions. Oh, I was just going to also say, yeah, so I do very much acknowledge my team members, my collaborators. If anybody knows, I'm looking to bring on a couple more like postdocs. So if you have any folks either on the clinical or the technical realm who might be interested. But I also really wanted to just really briefly grant as a junior researcher. The last year or so, I've been getting a bit more luck. I got one cool one last week, a competitive one from Canadian Cancer Society that I beat out a bunch of oncologists for. So that was a good feeling. But people don't talk at all enough about how hard it is to get grants. And this success was after literally over 20 grants being rejected in a row. So just to all my junior colleagues, this is a really hard time, and don't feel bad when you get tons and tons of rejections. Hopefully less rejections than I did, but it's definitely part of the game. And yeah, just wanted to mention that because nobody ever talks about it. Otherwise, very happy to answer any questions and hopefully you like my last little joke.
Sure. All right, let's open up the floor. Yeah, any questions for JJ?
Thanks so much, Dr. Nunez, for your fantastic talk, and I share your enthusiasm for AI. I have two questions. One is more broad, one is more specific. The broad one is more philosophical. What makes artificial intelligence artificial? Because I wonder, why is it the question is, will AI replace us, when really, how can we be more intelligent? Is my question. The second one is with respect to harnessing AI for health, leveraging it for healthcare, is every patient has many data points beyond Cerner, Care Connect, beyond that. But I'm thinking like social media, but also legally like BCCSO and other sources. How can we pull all these data points together to give us greater confidence in our predictive models? Maybe even have AI do formulations potentially. Thanks.
Okay. Oh, great questions, Austin. It's always hard because I can talk about this stuff for like so long, but nobody wants to hear me talk for that long. So okay, let's start with the second one. I think data access is the number one difficulty with the application of computational techniques to healthcare in general. I think, I mean, I could talk about my war stories of literally like 2, 3, 4 years waiting for data and having to meet with like the Ministry of Health and all that sort of stuff, right? It's really hard. And we, of course, need to balance privacy and security, right? This is really important. But we need to have health systems that could actually make data readily accessible for our patients, because like there's going to be a lot of harm that's done when we can't deploy these techniques that actually make a difference, right? And it's really cool in the last few years. Again, I gave my like banking example, and I do all this crazy stuff at home with getting my AI agents to connect to a bunch of different things, right? And this allows me to I have an AI agent that goes through my Gmail, my personal Gmail account, and will sort through everything and like give me receipts and book me calendars and all this stuff. It saves like tons of time, right? And it's amazing. But like I can't do that for my patients. I can't do that for my work email. I would love to for both if it was safe enough, right? So this is kind of a non-answer, but it is such a gigantic need, because if a patient would be comfortable that, okay, can I give you a bunch of data, or you want to give the clinician a bunch of data, then all of a sudden we could do a bunch of analyses, and oh, hey, you mentioned on Twitter that you're having this symptom that you didn't bring up, but that's actually really important, so maybe we could deal with that, right? So on and so forth. It's a really important thing. It's something we really need to think about. Obviously, balancing the security and privacy aspects and consent, that's really important, but it's I think the number one thing we got to figure out. Okay. Your first question, humans versus artificial neural networks. I mean, I think this gets really existential, and I think some of my neuroscience colleagues here would be probably better to answer this question. But, folks keep having this idea that there is this really big difference between human and artificial intelligences, right? Which I think is probably true, but at the end of the day, our neurons do work pretty similar like our artificial neurons, right? We have ones and zeros, we have a bunch of connections. Obviously, the architectures are different, and there's also the inputs of neuroendocrine systems and whatever else. But I think that they are, in a way, a bit more similar than they're not. But then we can also ask questions about like free will. We can also ask questions about like emotions and love and relationships. And that's what I see as the biggest difference. Maybe I'll end this very rambling answer with a common question I hear is about like, well, can AIs show empathy? And the answer is AIs definitely can show empathy. There's tons of studies that show that actually that they can outperform us when it comes to empathy, at least over over chatbots, right? They've had studies where the AI responds to you, the clinician responds to you, what's more empathetic, the AI wins, right? But to me, what's the important part is not the empathy, but the relationships, right? And I think that's what Freud told us 100 years ago, that developing these relationships is actually what matters. And that'll never be replaced by an AI for a bunch of different reasons, though that is, people are trying to do that, right? People are trying to, developing these relationships with chatbots. And obviously that's never going to be beneficial like a human. And that's why I started out saying that I think AI really should, we should really be using these tools to foster and build up the relationship that clinicians and patients have.
So you were talking a little bit about the importance of the patient-clinician relationship. And I'm just curious, in this world where patients agree to give access to all of this data, including their social media posts, do you think there's any potential of damaging the patient-clinician relationship when bringing up stuff that they didn't directly talk about? So like, I saw your Twitter post type situation.
Yeah, that's a great question. I think I'm being, maybe I answered that question a little too quickly, right? Like, I think having a lot of the clinical data to me is pretty important. But it is a good question, right? Do the social media posts? Yeah, and I think we could think about it further about like, as a psychiatrist, I think we're very used to talking about these like in-depth social things, but that patient still has that decision to be able to talk or not, right? So could it damage? I don't know. That's a really great question. I think so. A part of our research program that I didn't talk about too much is talking with patients and clinicians and potential users and figuring out what are folks concerned about in terms of AI. Right, and a big concern is this question is like, is AI going to make relationships with our providers worse? Is it going to degrade it? Right, and I could say that what research has shown for AI scribes is that when a clinician isn't having to write down everything and remember anything, it potentially could actually improve the relationship because you can actually sit there and talk with them and hear from them. So I think that's a really great example. But is there a risk that the more data we give, the more that could influence things? I think so. I know it's a great question.
So in different professions, like I guess you're in oncology as well, that you would, as a patient, you might get a lab report and it'll say you have a, 8mm mass or something. At some point in psychiatry, are we going to be giving the patient like all this additional information or what the LLM thought of them or?
I think patients would probably already really enjoy if they got a report of what you're suggesting to do to them, right? Like, how many of us will be like, oh, you should take this medication and exercise, and if they could get just a printout that just shows what we're recommending to them, I think that'd be really helpful, including the diagnoses. But what do you think would be helpful? Like going more into the symptoms and stuff?
I don't know, because it's all going to be there at some point. If we decide that we're going to use these machines or that they're going to distill CAN-MAT guidelines, and then people are going to get a clinical label of something. Should they be given all that information and be part of the report, I guess?
Yeah. So right now, at least at PHC, I don't know elsewhere, we have the new portal that allows patients to access their notes. And they blocked this for psychiatry, so patients can't easily just see the clinical note that was given, or that was written. They can still request it, but it's not through the portal. You have to go through a different way, right? And so I don't know. I guess one application could be: do you want to use AI to make a patient summary that maybe doesn't have all the details that we might not want to be in there? That would be still really useful for the patient. I think that'd be quite interesting.
You mentioned that sort of one of your dreams is to be able to create tools that will eventually help you foster a better patient and clinician relationship. And I'm just wondering what you think are the biggest barriers to actually being able to deploy these kinds of tools in British Columbia, I guess, or here.
Yeah, no, I'm really happy I have a lab now and folks, because I spent most of my time talking with like PHSA IT and trying to actually get this stuff permitted, right? So I think that's such an application. I mean, I don't know if any of you have tried the so Cerner, the people who make our EMR, has a clinical AI scribe. Right? It is so behind every other potential agent you could imagine, even though this is made by Oracle, which is the biggest companies. Like literally you can't give it a template and just it's if you guys get to see it as part of the trial, it's really interesting, right? But like them having that access to the EMR and having all the notes, I mean, they could potentially do so much cool things, right? So I think really, again, going back to the interoperability and the API, that's the hardest part, right? We have like FHIR and other ways that should allow this to happen. But I want us to be able to just like have an API open that, as long as I authenticate it and have the patient consent and everything else, that we could build AI tools that just connect to Cerner and then do a bunch of amazing things, summarize the patient's data, pre-fill notes, blah, 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 blah. So and I was having a great chat earlier about the implementation aspect of AI, right? Because there's so much work doing, all this cool stuff that you get a nice paper for, it looks really great, and then it never actually sees the light of day. And so we need to get to that point. And again, the biggest roadblock, why is every programmer out there using these agents all the time? Why am I doing this in my personal life, but we can't do this as clinicians? Again, it comes down to the access, and we need to do this safely. I'm not saying it's not important, but we need to improve this and get faster.
Thank you so much, JJ. We look forward to your research ahead.
Thank you all.
And just to echo what JJ said, last month I was out in Singapore, and within their hospital systems, everything is integrated, and they're really pushing ahead with the integration with the AI tools into their health records and such. So it's going to take a while for us, unfortunately. Thanks, JJ. Now, the next speaker that I have the pleasure of introducing is Dr. Sinan Guluksuz. I hope I kind of pronounce your name without, that's reasonably close. He's MD, PhD. Dr. Guluksuz joined the Department of Psychiatry in 2026, just very recently, as an associate professor based on the Northern Medical Program in Prince George. He received his medical degree from Gazi University School of Medicine, Turkey, followed by an MSc in affective neuroscience and a PhD in mental health and neurosciences from Maastricht University, and a postgrad certificate in medical education with distinction from Cardiff University. Prior to joining UBC, Dr. Guluksuz held a tenured associate professor position at Maastricht University School of Mental Health and Neuroscience, and an associate professor adjunct position in the Department of Psychiatry at Yale School of Medicine. He is a leading expert in psychiatric epidemiology with a focus on understanding the exposome, the totality of environmental exposures over a lifetime, and how it contributes to the development of psychiatric disorders, disorder trajectories, and also resilience. Thank you.
Thank you very much for the introduction, and thank you everyone for being here. I know actually how diverse is our department, and it's a beautiful diversity in terms of we have clinician scientists, we have basic scientists, and also translational neuroscientists. So with this presentation, I hope that I can embrace this diversity. Of course, I just need to simplify things, and I'll just keep things a little bit short to make the time. But of course, if you have questions, come and find me. we can always go deeper. Hopefully, each one of you will find something interesting. So before I begin, of course, I would like to acknowledge that the land on which I work is the traditional territory of the Coast Salish peoples. And I also would like to acknowledge that the land, because I'm coming from the north, that the land on which I live and work is the traditional territory of the Kaitane First Nation. I have no conflict of interest, except that I've received funding from these agencies. Of course, I'll get to the youth champs, but every project has an origin story, and this is how we began with testing gene-environment interaction. In the EUGI study, we focused on psychosis particularly. We collected a large, deeply phenotyped sample, including patients, their siblings, and the healthy controls. And it really gave us some really important insights about gene-environment interaction. In this core paper, as we actually anticipated, that we showed that the polygenic risk score for schizophrenia increased the risk for psychosis, while the environmental exposures from different childhood trauma domains, cannabis use were also associated with psychosis, except the winter birth, the season of birth, winter birth, which is considered a risk factor. But the novelty was this. This was the first time that we showed an interaction between molecular genetic liability for schizophrenia and some of the environmental factors, including cannabis use, bullying, sexual abuse, and emotional abuse. And to put simply, the environment and genetics do not simply add up. So in a way, the combined influence of genetics and environment is larger than the sum of individual effects. And of course, when I was working on the UGI data, something struck me, that our approach to environment is much more simplistic when we actually study genetics. So we were limiting ourselves. I mean, let's be honest. And then you saw that the polygenic risk score for schizophrenia is far from being perfect, obviously. But I mean, I was impressed at that time how easy to apply these genetic risk scores in data sets. And that got me thinking, can we actually build something similar for the environment that is just like a single total score for environmental risk for schizophrenia? And from the start, because the applicability over complexity. So in order to make this applicable across data sets, it has to be using the exposures that were established, universal, and mostly measured in all data sets, most data sets, I would say. Because not like the EUGI's particular study that we have all the variables that we collected in order to test social environmental theories. But not all data sets have those like variables. And that's why we took these 9 exposures that were, again, well-established, universal, and usually measured in most data sets, and we combined them into one cumulative score using predictive modeling approach. And the numbers were actually respectable with the area under the curve, about 80, and the solid explained variance, like 28%. Again, these are not like going to be like, it's not the clinical, standard, but quite actually impressive. And now we have a tool to work on in different data sets. After that, we put the exposome score to work. In my lab, actually, we used different data sets. We tested, different scenarios from different angles. So, and also others used the exposome score in BSNP data set, for instance. So how can we actually use it? We can use it as an index of environmental predisposition to test gene-environment interaction, environment-environment interaction. We can use it to stratify risk when we want to actually build risk-enriched cohorts for prevention research, as well as we tested the exposome score in first episode psychosis, chronic psychosis, to look into, to forecast the course and outcomes like functioning, like symptomatic remission and response. And the results are actually very impressive because we tested this in Greek first episode psychosis, different countries, different cohorts that were consistent. And of course, in the long run, we can integrate with transdiagnostic clinical staging to predict real-world decisions. And one of the beauties is that collecting this information costs almost nothing, and we can actually really minimize the time to collect this information as well. So I only gave you a small preview, and I'm excited to say here for the first time that the version 2 is coming soon. So it will be much improved and different angles, not just the schizophrenia angle. So we are still working on it. And the EUGI gave us insights, of course, and it gave us tools. And for me, it was foundational for my career. And happily, that there was an interest, and the interest in gene-environment interaction, and particularly the interest in environment, keeps growing. So that brings us to UCHEMS, and that is our recent EU project. So you may ask why young people? That's because for two reasons. First, it's a window, a critical window for mental health. Most disorders actually emerge at that time, so that we can really study the origins of illnesses at the onset. And second, you see, like, the numbers are sobering. I mean, every clinician would agree with that. The young population is not in a good place. And of course, studying young youth brings us opportunities, but it also brings many challenges. And over the next few slides, I'll just talk a little bit about the layers, these different layers of challenges, and how we can actually turn them into opportunities. And if I start with the layer, the phenome, every clinician in this room knows the problem. Our diagnostic categories are messy. They overlap a great deal, and particularly this is even much more complex during neurodevelopmental period in young people, because the trajectories are fluid and the symptoms always shift, and they are not really specific. They are pluripotent, meaning like one specific sign can lead to very different outcomes. It's not like psychotic experiences or psychosis expression to schizophrenia psychosis. And they are deeply personal. So instead of studying categories, we embrace transsyndromic thinking in UCHEMS. And the second layer is the exposome. So too often we study environmental factors one at a time, but the environment, as I said, is really a dynamic network. And especially during neurodevelopmental periods, the details matter even further because the timing matters, the duration matters, and how many times this exposure repeats, it also matters. So we need to look at the exposome as a whole instead of focusing on one environmental factor. And of course, the third layer is at the level of molecular biology. So that's something that we know, that we appreciate. The genetics is polygenic. So that's just very well known. These are thousands of tiny variants, each adding a little risk. And they're also pleiotropic, meaning that the same variants are linked to different outcomes, again, different mental disorders, and also even physical disorders, physical diseases. And here is also something that we are now increasingly appreciating, is that our DNAs are static, but our gene expression is not. So it changes over time, it differs by cell, it's stress responsive. In a way, the stress can switch on and off the genes, and that's also, of course, the epigenetics part. And so with the UCHEMS, we want to go beyond the simple genetic liability for phenotypes and try to understand the biological underpinnings of sensitivity to environmental vulnerabilities, which through using biologically informed polygenic scores. And these are our big aims, two big aims. The first is to understand the biology of the underlying of the gene-environment interaction underlying mental health trajectories in young people, and the second is to provide young people and health professionals practical tools. Now, of course, these are ambitious goals, and that's why we built this interdisciplinary consortium. We have neuroscientists, clinicians, data scientists, young people in our group from 11 countries, spanning Europe and even Australia as an associated partner. And we have 7 work packages that work simultaneously. I'll just walk you through all these work packages. But these are the key people within our consortium. We are just, of course, a larger group. And I'll be honest, I hate the red tape of the EU, budgeting, the reporting, everything, annual, like quarterly. But I love working with these people. Like I actually, being in this kind of consortium and different perspective, different backgrounds, it just really enriches the view and of course, and I'll show you what we have achieved so far. So I'll start with the heart and soul of our project. It's a work package 2. It's all about the young people, actually. And from the start, we have been firm believers that young voices are key to our success. And we have been actually collaborating, working together with young people from Euro Mental Health from the start of the project. Not actually from the start, I need to just correct it. From when we were writing the grant application. So that's how we started. And Youth Champs is all about sharing, reflecting, and connecting. We have monthly science cafes that we address specific research questions or how we can disseminate findings. We just ask young people, and then their answers actually directly shape our views about how to communicate or how to guide the next upcoming studies. We have, of course, website, social media activities run by this work package, as well as we also are in close connection with the other projects that were funded in the same call. So we share our findings in order to move the field forward. And if work package 2 is the heart and soul, work package 3 is the brain. So it's just the data management, but it's not only data management. It is also it also delivers the federated discovery and learning platforms. So I'll just explain what this is actually. So the idea is federated analysis. In the old times, I mean, good old times, like we were able to download the data, transfer the data, or collect the data in one place and analyze it. But things are getting much more difficult. Particularly data leaks are common. I mean, look what happened even in the UK Biobank. And the regulations actually keeps getting stricter. For instance, our partner in Finland cannot move data across their borders. And what we do with the federated platform, instead of moving the data, we move the analysis. So we train the models locally and then we aggregate the parameters so the raw data always remains in place. And we have already built this platform. Of course, we tested with this simulated data before the clinical study is complete. We keep improving, and hopefully that will be even readier. And moving on to the work package 4, which is the core neurobiology work package. And it has 3 aims with the ultimate goal of generating developmentally informed, biologically grounded transsyndromic polygenic scores. I know it's a lot to say. So here's one of the early results from that work. In this largest study to date of cortex DNA methylation from 6 post-conception weeks to 108 years, that we found developmentally regulated changes in DNA methylation and particularly pronounced during early and mid-gestation that were distinct from the age-associated modifications in the postnatal cortex. And we also demonstrated evidence for neuronal specificity, and that were some of these DMPs, some of these the changes were enriched near autism and schizophrenia genes, and particularly the signal was strongest in neurons. So these findings actually provide further support for neurodevelopmental theory, origins of these mental disorders. And the other goal, of course, is to understand the genetics of mental health trajectories. But the usual genetic tools like the polygenic scores do not really fit to youth psychopathology, as I just discussed, because they are restricted to traditional disorder categories. So we use the genomic structural equation models in order to dissect shared and differentiating genetic liability. We first applied this for schizophrenia, bipolar disorder, and MDD. And lately, we extracted the further differentiating components from each identified factors from the study by Grotzinger and their colleagues. Again, these like differentiating polygenic scores are not designed actually to detect or predict whether someone is at risk, genetic risk, but rather they inform which type of psychiatric presentation that risk is most likely manifest as. That's what we are interested in, particularly in work package 5, to understand better the underlying gene-environment interaction, the mechanisms. And something we acknowledge is that some variants only matter under stress, and the standard genetic score misses them. This is particularly important for us because we're interested in understanding biology of gene-environment interaction. So that's why we've just recently generated these stress-dependent functional polygenic scores. So it's a weighted score, but I'll walk you through the steps from the first until the weighting. And so we just use the GWAS hits, take the GWAS hits. We just, in order to measure the enhancer activity, we synthesize these GWAS hits into the self-transcribing star sec, and then get those and put them into the hippocampal neuronal cell line, because hippocampal neuronal cell line is stress relevant and relevant for all, of course, for depression. And then we apply stress using dexamethasone to mimic the cortisol to simulate stress, and then measure the regulatory activity, and then using these as weights, we compute the functional polygenic scores. So this happened just last week, so I'm just excited to apply them in work package 5. So this is actually the work package 5 is where we apply these insights in large population-based data sets. And as you can, one of the real beauties here is that we work across many youth cohorts from A, B, C, D to Generation R to ALSPAC, and this gives us a huge advantage because we can both replicate our findings and as well as we can look into the same question from different angles. And I'll show you the very early findings. Of course, I'll start with the studies where we applied the exposome score for schizophrenia for the first time in this course to test gene-environment interaction. There's so much, of course, effort and details here, but to make the time, I'm just going to only show the key findings from these studies. And in this study, using the ABCD cohort, we showed gene-environment interaction using the exposome score and polygenic risk score for schizophrenia, and that were both independently and jointly associated with psychotic experiences in early adolescence. And as one of the most neglected areas is the sex differences. So next we asked whether sex can make a difference in the same cohort. The results actually were interesting because we found that the influence of genomic risk for schizophrenia might be sex dependent, whereas the exposomic risk was more universal. And building on these findings and given the potential role of estrogen, and again, the limited research on how early female puberty development influences mental health, we investigated the role of puberty factors and psychosis expression in girls within the context of genomic and exposomic risk. And we just showed that the higher estradiol, earlier age of menarche, and latent pubertal status increased psychosis expression. And we didn't actually, these were not moderating the effects of exposome and polygenic risk score for psychosis. And then, again, we attempted to replicate our findings that we just found in the ABCD, now in transferred to the ALSPAC. In this case, we didn't fully replicate our findings. Again, the exposome score was predicting the risk for psychosis by psychotic experiences, but not the polygenic risk score for schizophrenia. And we didn't detect any gene-environment interaction, but the combined high-risk states further increased psychosis risk. And just recently, we applied, again, in a different cohort, the UK Millennium, the transdiagnostic polygenic scores that we gathered from the work package, transferred from work package 4, in the UK Millennium cohort. And here we constructed the trajectories using the STQ domains, such as the internalizing, externalizing problems. And we found that the MDD differentiating PRS showed the broadest significant associations, suggesting that like MDD actually, the genetic liability MDD could be shared. And now we're actually extending this work using the Grotzinger factors and testing this in 4 different cohorts. So that will actually give us a better picture, because it's very, in a way, agnostic, in a way not hypothesis-driven, that what we analyze it. And we've already started to build on the UCHEM's experience, adding new directions. So I feel privileged to mentor my brilliant postdoc, Bochaldin, over several years, and now through her NARSAT project. And in this project, we bridge 3 dimensions: the exposome, genome, and neuroimaging. And through transgenerational approach, we test this fascinating idea is the genetic nurture, meaning that the parental genes, the shaping child through the environment and not just through the inheritance. So, and finally, in the work package 3, like we will ask how gene-environment interplay shapes the developing brain, and particularly looking into the cortical gyrification. And this is our most practical work package 6. It runs from building AI-based predictive models, which I'm not going to actually just discuss today, through to developing digital tools we can actually act on. And this is one of the digital tool that we generated, a GDPR-compliant mobile app co-created with with users, young people, clinicians, and researchers to collect passive and active, and as well as digital phenotyping data. Again, through the process, I learned a lot. One of the things I learned with the digital data and mobile app collection is that as long as the user actually trusts you, the feasibility is not an issue. That you can collect massive data. That's also a good thing. We have lots of computational power to process the data, but the main limiting factor is the phone battery. So, because an app running in the background drains the battery so quick, and people, even if you just improve it, people complain about it a lot, and rightfully so. We also complain when we are using our cell phones daily. And the other thing, of course, in the changing world, the data privacy, the regulations change every time, and EU is, of course, as you know, is much strict, and it's much more difficult to navigate things. Those are the main challenges. And the proof of concept clinical dashboard that we are just actually building this. It's still proof of concept. So that the single place for clinicians and researchers that they can actually look into the digital media immediately after collection. And we are hoping to also integrate some AI into, I kind of feel, I always hesitate using the word AI, integrating AI. What do we mean by AI, as JJ actually just discussed. And this is the clinical heart of our project. It's all about clinical innovation, that we are running the first international trans-syndromic longitudinal clinical cohort study of help-seeking young people in 6 European countries that cover all 4 regions of Europe, which makes the sample diverse, in a way at least representative. And so before we start the project, of course, we had this question that we needed to answer. Which clinical measures should we use? That's the challenging part, because we don't have so many transdiagnostic trans-syndromic studies, and particularly within this age range. And we actually did our lesson, homework, and then we ran the systematic review, and the results were actually sobering. So because it was all over the place, 242 outcomes, collected using 140 instruments, no overlap. Anxiety, depression were the ones that were actually collected the most, because of course it makes sense, but at the same time, the positive factors, particularly young people, emphasize more the functioning, quality of life, resilience, well-being. They were not measured. And none of those measures were co-created with young people. And this was actually quite a moment where I just think, how are we going to actually replicate our findings, or how are we going to, just because it's also one of the difficulties with working with this kind of young cohort from 12 to 24 is that we have this arbitrary cut point 18. And most scales actually either measure before or after 18 years old. And this is our clinical study. We're collecting 1,000 young people between the ages of 12 and 24. Any psychiatric diagnosis. The only criterion is that they need to be first-time help-seeking and first-time mental health service users, actually, within the first month. And we are collecting data over 2 years, from baseline to 24 months. Only baseline is in person, and we're collecting large sets of biological biomarkers, particularly immune markers, and some niche immune markers, I would say, the super and complement. Obviously, genetics, epigenetics, clinical deep phenotyping, and environmental data, social lifestyle, and digital app. As well as, one of the beauties is that we are associated partner, that they are collecting the Kids Are Not Okay study, so that we will be able to use both data sets. So this is actually usually because I just work both ends, running a clinical study is hard. So because I just use the existing data sets, I also just, as a clinician, do the clinical studies. It's from ethics approvals to setting up centers to motivating people to recruit is just the most stressful part. That was the case when I was in the EUGI, and still the case. But honestly, we are doing well. Even though we started late, we will be able to reach at least 90% of what we actually promised, because our partners are wonderful. From Spain, from Serbia, they're extremely efficient in collecting data from patients. And the other thing, it is much better retention rates than I anticipated when we were writing the application. So 84% is actually remarkable. So without further ado, I would like to thank all the people actually involved in the youth jams. And obviously, I would like to thank my team in the old country. They've been my rock for many years. I couldn't have done without their support. And thank you so much. The last time I checked, the score was 1-0. I think, 3-0. Okay. That's nice. Maybe we brought luck. You can say that. Thank you so much.
Thank you, it has that very thorough talk, very thoughtful, beautiful talk. Maybe given the time, maybe just one question. I've got a question. I have never heard of that term exposome. So just from a definition, that's everything.
That is the totality of the environmental factors. That the term actually was coined by Dr. Wild because particularly it's like the om is the Greek affix, like for the totality of something, and the genome is the totality of genes, and the exposome is the totality of the exposures. And this was actually sort of introduced to complement, because that was particularly in 2007, like there was so much investment and so many research going on in the fields of genetics. It was those 2000s were defined as the human genome era, and the term was coined in order to complement the
human organism being complicated, does that include our gut bacteria and all of that?
Exactly. Yes. That is actually part of the internal exposome. Like the gut microbiome is also considered part of the exposome. So from external toxins to childhood trauma to even I think different layers. Like because one of the top layer is the policy and governance that make our environment. So, but it's just a very broad term to define the totality of the exposures that a person is exposed throughout their lifetime.
Thank you for bringing this interesting
ideas. Thank you so much. Thank you.
Hi, thanks everyone who stayed for the remainder of the day. My name is Trisha Chakrabarty. I'm a faculty member and a member of the organizing committee. So we are going to end our day with the presentation of awards. But before I do, I just want to extend a huge thank you to all of our speakers, from our trainee speakers who presented at the lightning talks, to our poster presenters, our two fascinating faculty speaker talks, and our plenary speaker. Also, a big thank you again to the administrative staff who were really, foundational in putting today together. So we'll start with the presentation of awards. So the first one is the 2026 Nisea Laura May Alvin Memorial Prize in Schizophrenia Research. This goes to a trainee within the department who published a pivotal paper in the subject of schizophrenia, and this goes to Miss Katie Futhi, who published Integrated Clinical and Postmortem Profiling in Schizophrenia. Our next award is for a resident who made significant contributions to research or scholarly activity. And today that goes to Dr. Sayun Hakobayan for her publication, Concurrent Disorder Management Guidelines, published in the Journal of Clinical Medicine. Is Dr. Hakobayan here today? No, don't see her. So we'll get her plaque afterwards. Next, we're going to go to the Poster and Lightning Talk Awards. So we'll start with the Lightning Talk Awards. So these were based on your votes. So the most popular Lightning Talk from the morning set was Dr. Nicholas Ainsworth, who presented on his project in L-DOPA for late life depression. And then from the afternoon, it's Dr. Tom Sorowski, who presented on the ketamine program in Squamish. So yeah, you both can come down. Lastly, we have our posters. One is given for a poster in basic science, and the second for translational or clinical work. So Ms. Hengame Marzvani for her poster, as well as Adam Sunofsky. I'm guessing Adam's not here. Okay, well, that concludes our research day. Again, thank you so much for coming. Please do take a chance to look at the e-poster gallery at some point, but otherwise, enjoy the rest of your evening.